Morning.
It's 8:30. We'll go ahead and begin. Try to stay on time again today. Thank you for your patience yesterday, and thank you for your attendance again today. Welcome to day 3 of the joint appropriation hearings for FY22 amended and the FY23 budget. We're going to get started. We should be wrapping up today around, let's see here. Get done a little after lunch with our block grant hearings. We'll run till 11:30 with commissioner reports, and then take a lunch break and come back for the 2022 public federal block grant hearings this afternoon. And I believe Chairwoman Dempsey and Chairman Watson are going to chair those for us afterwards. We do have Chairman Perkle up here with us today. Chairman Perkle, do you have any beginning comments?
Not especially, but I would like to open us in prayer. So if you bow with me, dear Heavenly Father, Lord, I thank you today. Blessings. Lord, I'm so thankful for the blessings that you've given us. The rain is falling. I'm thanking you for that. I pray that you'll have safe passage as peaceful people drive to work and to here. Give us great wisdom. Amen.
Thank you, Chairman Perkle. Our first presenter has already made her way to the podium. We've seen her in different roles before, but it's good to see you this morning, Commissioner Candace Brose from the Department of Human Services. Commissioner, you've got the floor.
Good morning, Chairman Tillery and committee members. I'm honored to join you to discuss the governor's budget recommendations for the Department of Human Services for amended fiscal year 2022 and state fiscal year 2023. Before I get started, I'll briefly introduce the members of my leadership team with me today. My Chief of Staff, Craig Foster, Senior Deputy Commissioner and Deputy Chief of Staff, Chris Hempfling, Deputy Commissioner for Finance, Demetrius Taylor, and Assistant Deputy Commissioner for Finance and DFAC CFO, Cliff O'Connor. As you know, last summer, Governor Kemp appointed me to serve as Interim Director of the Division of Family and Children's Services, and he subsequently appointed me to dually serve as DHS Commissioner last fall. In taking on these new responsibilities, I focused on learning the intricacies of our agency and worked with my leadership team to strengthen the continuum of care for children in state custody, the aging community whom we serve, and the families relying on our services for healthcare, food, utilities, and financial assistance from non-custodial parents. Despite leadership changes and the pandemic, our agency's goal remains the same: stronger families for a stronger Georgia. Our workforce continues to demonstrate their commitment to that goal through hard work and determination, even in the toughest of times. In accordance with the governor's mission to protect lives and livelihoods, we have worked tirelessly to strike the right balance between workforce safety and constituent needs. I'll touch on each division's current COVID operations. In the Division of Family and Children's Services, Child Protective Services never stopped emergency in-person investigations. For those staff who handle benefits eligibility for programs like Medicaid, SNAP, and TANF, we're operating virtual lobbies through the call center. To avoid one infected employee from knocking out an entire office for quarantine, local DFAC's offices continue to follow an appointment-only model. Child welfare workers still go to court. They still do in-person home and facility visits unless there is a COVID outbreak. Benefit eligibility workers are almost entirely virtual, which is conducive to their daily work. We're meeting our milestones while actively preparing for when we can safely reopen our doors for walk-ins, and we're developing a plan for certain regions to have designated offices open for walk-ins, aiming for March. In the Division of Child Support Services, local offices also utilize an appointment-only model, which has worked well, and we were able to meet our annual federal paternity requirements to avoid federal penalties. In the Division of Aging Services, Adult Protective Services never stopped working with law enforcement to refer complaints of abuse, neglect, or exploitation for emergency dispatch. When you add our budgets and those of our agency's attached entities, the department's total proposed fiscal year 2023 budget allocation is $1,989,237,266. And so now I'll pivot to discussion of the governor's recommendations for our agency. For amended fiscal year 2022. On behalf of thousands of frontline workers who keep our children safe, ensure children receive financial support from non-custodial parents, pay our Georgia families with resources to keep them intact, and protect our elderly from abuse and exploitation, I want to thank Governor Kemp and First Lady Marty Kemp for their proposed workforce package in AFY 22 and FY 23. That $5,000 pay increase is going to change their lives. Our staff don't do these jobs for the pay. They do good work because they believe in what they do and they want to make a difference in the lives of those whom we serve. That $5,000 represents a 13 to 14% increase in pay for those brand new social services specialists working in child protective services and foster care. And it's a 16 to 18% pay increase for those entry-level staff working in child support services, as well as those staff who connect families with Medicaid, utility bill assistance, and food stamps. Throughout DHS, you'll find employees who are deeply grateful not only for this historic pay increase, but also the higher employer match, as well as the option to withdraw leave as pay for unforeseen emergencies. Longtime veterans have described this workforce package as the best they've seen, and for a team who smartly weathered budget cuts to become more efficient, it's a welcome reward for doing more with less. You'll see in each of the respective program budgets in AFY 22 and FY 23 adjustments to reflect those workforce incentives, so I won't go through each of those, instead focusing on new additions to AFY 22 for specific initiatives, starting with departmental administration, page 221. Recommended change 2. There's $4,016,595 to cover a funding gap for enhancements to the state's integrated eligibility system, Georgia Gateway, which is used to determine a person's eligibility for benefits like Medicaid, SNAP, TANF, and utility bill assistance. Next, in the Elder Community Living Services Program budget, recommended change 2, you'll see $2,718,854, which will draw down $37,993,513 in federal funding from last year's American Rescue Plan. And with that match, the state will serve an additional 5,731 clients over the next 3 years with supportive services, congregate meals, home delivered meals, and additional caregiver services. In FY 21, for example, we served 40,146 clients with home and community-based programs through our 12 area agencies on aging. Those are the only 2 adjustments in AFY 22 outside of the workforce recommendations. So I'll now move to his recommendations for fiscal year 2023. I'll go to FY 23 Child Welfare Services, page 225. First, for recommended change 6, you'll see $1.5 million to fund a new pilot for community action treatment teams. A few years ago, Florida's legislature included funding for their state child welfare agency to contract with 24/7 healthcare treatment teams comprised of a physician, nurses, behavior aides, therapist, a social worker, and an administrative support specialist for state officials to deploy this team of experts to serve a high-needs child, medically, behaviorally, or both, in that child's home, if possible, delivering tailored care and increasing the odds of that family remaining intact. In other words, reducing the risk of foster care. Those same teams can also serve children in foster care living with kin or a foster family. Currently, our agency employs a part-time physician who reviews medical records, evaluates assessments, and checks prescriptions for contraindication. Her work is immensely helpful as we work to address a child's needs on managed care Medicaid. But her work and our work is primarily focused on children already in foster care. We want to dramatically increase preventative services, especially as we face a rising incidence of parents feeling forced to abandon their children to foster care because they cannot seem to find the right resources for their high needs, delayed, or disabled child. With your blessing, our agency will hire these healthcare strike teams and deliver care where families need it most, at home, in person, available around the clock, and tailored to that child's needs, with that child surrounded by their loved ones in the setting they're most comfortable. Next, for recommended change 7, you'll see $451,978 for an autism assessment pilot in Region 12, which covers Bryan, Bullock, Camden, Chatham, Effingham, Glenn, Liberty, Long, and McIntosh counties. Some of you know Dr. Michelle Zena, a physician in Statesboro, who specializes in diagnosing and treating children with autism spectrum disorder. I've worked with her over the past 6 months to develop a proposal where she and her team will screen every child in foster care in Region 12 for autism and ideally publish her findings in partnership with Georgia Southern University on the prevalence of ASD of youth in state custody. Why is that project important? We have anecdotal evidence that the prevalence of autism among children in foster care is higher than that of the general population. We're also dealing with more parents abandoning their children to state custody because of unmet mental and behavioral health needs, the difficulty in finding providers able to meet the level of care for those children, The sheer amount of staff resources going into coordinating their care, frequent placement disruptions, and that those children, usually teenagers, often have the same cluster of diagnoses and behaviors. What we most often see for youth with complex needs without suitable placements are PTSD, ADHD or ADD, autism or suspected autism, self-harm, physical violence to others, mood dysregulation, oppositional defiance disorder, anxiety, and depression. And they're in and out of emergency rooms or psychiatric facilities. This project will help us better understand whether we're missing the right diagnosis altogether, diagnosing it something else, or improperly treating. It'll help us as a state better marshal the right resources to the problem if we understand the actual prevalence of autism in that region. And it'll help us strategize more effective time-sensitive therapies to get to these kids younger when therapies are most effective before they risk entering foster care. The remaining new item in this program budget is $1 million for autism respite care. This funding will allow our agency to contract with providers to offer more respite services for families, not just for children with autism in foster care, but also for those families experiencing burnout, when caregivers may consider relinquishing their rights if there's no reprieve on the horizon. We have a lot of work to do to improve the continuum of care for ASD. I am deeply thankful to the governor and First Lady for including these recommendations, and with your support, we'll be able to make life-changing improvements for our most vulnerable children. Shifting to page 227, recommended change 2 for out-of-home care. Importantly, of all our program budgets, this one is the most variable. We never know how many children will enter or leave foster care on any given day. No staff are paid out of this budget. It's where we pay foster parents, child placing agencies, child caring institutions, and what we call supplemental supervision, which covers what we pay through wraparound services like behavior aids, as well as hoteling costs, including the rates for those who stay with the child in the hotel or DFAC's office, that child's meals and transportation, and the remaining costs of his or her supervision. Hoteling. Many of you are familiar with this term, which means a child in foster care has been temporarily placed in an office or hotel, stemming from a lack of foster families and group homes able to accept youth with complex needs. We've marshaled more resources, man hours, and flexibility to proactively address this problem. Over the past few months, we've piloted enhanced provider rates on a case-by-case basis to keep kids out of hotels and offices, and to remove them from hotels and offices into placements tailor-made to serve their needs. We also started paying outright for necessary health services so that a child's behaviors rooted in trauma didn't jeopardize them from being able to safely remain with their foster family or group home. Since July, when I was appointed interim DFACS director, and when the state was averaging 50 to 60 children in a hotel or office on any given day, we've prevented at least 60 children from ever being hoteled. The Monday before Thanksgiving, we had 70 children temporarily placed in an office or hotel. We'd managed to get down to the 40s before we saw that jump back up, but in only a week and a half, we got that number down to the 30s, the first time it's been that low in years. Unfortunately, the Delta and Omicron variants have temporarily sidelined the effectiveness of our strategies, but we're working closely with the Department of Community Health and the Governor's Office to secure emergency staffing for providers which have been forced to take placements offline. Once we address this temporary staffing issue, we'll get back to aggressively identifying better placements for our kids and free up bandwidth to plan for more preventative work, keeping more children out of foster care altogether. So with that background, I'll turn to this point. You'll see that the governor has included $27,810,584 in out-of-home care to raise what we currently pay foster families, child placing agencies, relative caregivers, and child caring institutions, AKA group homes, by 10%. The impact that this new funding will have on recruitment and retention of high-quality caregivers for children in foster care cannot be overstated. Foster families aren't in this business for the money, nor are child placing agencies or child caring institutions. In fact, many of you know, I'm sure from personal experience, that your friends and those nonprofits in this line of work are, financially speaking, in the red. A provider rate increase will give foster families more flexibility to meet the needs of the children in their homes. If they need shoes, clothes, school supplies, a haircut, or they want to do extracurricular activities, this increase per diem means our foster parents aren't taking as much of a financial hit by opening up their homes. It means that our group home providers can recruit better, high-quality staff to care for children with unique needs. And as we continue to battle the effects of COVID, workforce challenges, and inflation, these increases will prevent foster families and providers from leaving our ranks. Right now, we cannot afford fewer homes to keep youth safe and address underlying trauma, not if we want to be more aggressive about deploying preventative services, identifying appropriate placements, and holistically improving the continuum of care. Now, I'd like to take a few moments to highlight the divisions of aging services and child support services. As we spotlighted in our annual report, aging services continued its work to safeguard vulnerable adults from abuse, neglect, and exploitation, and provided resources to support older Georgians, persons with disabilities, and their caregivers. For example, participants of the Senior Community Services Employment Program volunteered over 44,000 hours of service, including over 19,000 hours of service to organizations serving older adults. And the Georgia Fund for Children and Elderly, which is co-administered with DPH, provided home-delivered meals and transportation for seniors as we continue to battle the pandemic. The Division of Child Support Services continued working to build stronger families by getting children the financial support that they need and equipping parents with more tools to provide for their children. 8,121 new parents enrolled in the Fatherhood Program, which connects parents with training and employment opportunities. In FY21, over $10 million in child support was collected from fatherhood participants, and 1,761 children received increased support from parents who participated in Georgia's Parental Accountability Court program. Quickly, I will touch on $6.7 million originally added to the FY22 budget on the Senate side, specifically designated for therapeutic foster care. It's on page 227. It was added to ensure collaboration with the Department of Community Health for more therapeutic services reimbursable under Medicaid, but our federal partners have not yet granted approval. In the interim, these funds can be redirected for immediate needs, specifically the ability to fund more preventative services for children, which is a moving target exacerbated by the pandemic, by giving us flexibility to use it with an amended caption. Under the Child Abuse and Neglect Prevention Program budget, there's also a technical revenue item with $1,100,533 in dedicated state revenue for marriage and divorce filing fees, recognized via the Children's Trust Fund, while general state revenue support of this budget is reduced by an equivalent amount. There's no program impact from this technical change. It's just a clarification of what revenues are supporting our work in this area. I'll now touch on some exciting projects that we've recently initiated. We're in the final planning stages for implementing upgrades to our child welfare case management system, which right now is not caseworker mobile. If you're a caseworker going to do an emergency welfare check, going to court, visiting a foster family, you can't add notes or photos, review case history, or sync new data with our system if you're out in the field. You've got to drive back to your computer and type it in. Not only does that risk losing information because of the time gap, it's time consuming and takes away from personal interactions critical to a caseworker's job and child safety. We're also working on customizable software so we can better coordinate a child's care between our staff, foster families, providers, and everything in between, including an exciting new foster parent eligibility and training module to make it easier and faster without compromising safety to get approved to become a foster family. On the benefits eligibility side, we've made some very timely upgrades to Georgia Gateway. Right before the pandemic hit, we made SNAP or food stamp applications available online. We added new automation, and we're leading the country with bots, which help workers analyze data and process cases faster and more accurately, as well as automated appointment scheduling. By leveraging technology and automating our processes, we are alleviating burdens for our workers at a critical time. In my new role, I am intensely focused on improving mental health and behavioral health services for youth at risk of entering foster care or currently in state custody. With the Governor and First Lady's support, collaboration with my fellow health agency counterparts, and words of wisdom and support from you, we're going to ensure that every child who enters foster care has the best placement and resources to meet their needs. These budget recommendations invest in high-quality preventative services to keep kids from ever being separated from their families and to address their trauma if they do enter custody. In these budgets, we're going to gain a better understanding of the prevalence of autism among foster youth and build a robust network of healthcare services so children can access autism services at a younger age. We'll better recruit and retain high-quality foster care providers. We'll draw down critically needed federal funding to deploy supportive services and meals to aging Georgians who need it the most. And we're making strategic, positive investments through good government with an emphasis on a seamless continuum of care for all Georgians. Several of you, I want to personally thank. You know who you are. You've been invaluable to me as advisors and given me critical support as I've become familiar with my new role and everything that goes along with it. And I just want to say thank you for that. And I also want to close by thanking Commissioners Noggle and Fitzgerald, plus Director Farr and the Office of Health Strategy and Coordination, Director Grant Thomas, for collaboration to improve our services statewide. We're making some incredible gains with information sharing to better map out from the youngest Georgians to the oldest Georgians, what their experience is with state government and what we can do to make it better for them. With your support, we'll continue to build stronger families for a stronger Georgia. Thank you. And now I will happily take your questions.
Thank you, Commissioner. That was this your first time before the committee?
Yes,
That
sir.
was quite impressive. I actually, I mean, you act like a Georgia Tech person. I don't know what the deal is, but
It's true.
okay, well, it shows through. But thank you for that presentation. You did an excellent job in
Thank you.
explaining the funding and the reasons for it, where we are, and where we're going. And it was, this is actually one I'm going to go back and look at again. I was trying to write down feverishly some of the comments and the questions that I had, but there was a lot to pack in. One of the things that you mentioned, if I may, you mentioned regarding the hoteling, and you mentioned enhancements for providers. How does that free up this awful practice of hoteling? So there's additional capacity there,
Right.
if there was additional resources there. Is that correct?
Yes, sir. So the way that it currently works is, and you'll find this number pretty staggering because I did. On average, we spend about $1,200 a day to hotel a child. And they sit in the hotel or they sit in the office and they have their case manager with them, and they may have some behavior aids, but all the costs that go with that, you're not really providing the child with the health care that they need. And really, we're talking about children who are, who behaviorally are difficult, but also you'll see children who are developmentally challenged. And by essentially moving away from that model and going to providers, the ones that are already credentialed to, have the maximum level of supervision of children, we say, okay, this child has these needs. What would you be able to do if we pay you an extra $150 a day or $200 a day, which at the end of the day is a better deal for us. Honestly, it's not as expensive as hoteling, but it gets the child what they need, and it allows the provider to contract for more people to ensure the right amount of supervision and actually help them work through some therapies and get what they need. So that's really been the strategy. And we didn't know if it would work. Money doesn't fix everything, right? But it seems to be working so far. And once the Omicron variant came through, like I said, it did kind of sideline. But once we can get that emergency staffing, we're going to bring dozens of placements back online with some of our highest needs providers. And we really feel confident that we're going to make tremendous headway in the next few months to get that number as low as possible.
Well, that is a great, that's a great start. Then just providing a shelter and food, that we're actually meeting some needs of these most vulnerable kids. The second is through the pandemic. And it's difficult because of the pandemic, but a lot of our local offices, you can't get to them.
Right.
And so you'll make a call and it don't get answered. And I've tried. So you make a call and it doesn't get answered. What is your plan going forward that we can reach out? Because I mean, it's wonderful, the different myriad programs we have, but if you can't get access to your local office, it's not providing the level of service we need.
Right. And that's been a common complaint. One thing, whenever I moved over to DFACS, one of the first measures that we implemented effective September 1st was to actually start requiring in-person home visits again every month. Those were being largely conducted virtually. Now, that's not the emergency CPS calls, but the regular check-ins of foster children in their placements. And so we're trying to move the needle there. I think the reality is every agency is facing serious workforce shortages right now. If I wanted to try to reopen all of my offices, I know of at least 40 counties where I don't even have someone who would man the front desk. But, with a multi-pronged approach, putting in new technology so that you don't have to have as much, in-person interaction with data and other things, documentation, maybe we can then free up some people who do that work and get them into those offices. But we still are working on a plan where at the minimum, we'll have some regional offices that are open for walk-ins, and that plan is the beginning of March.
Thank you, Commissioner. You have several questions, and so I'd ask the members, if you will, get straight to your question. Senator Kirkpatrick.
Thank you, Mr. Chairman. Thank you, Commissioner. You've obviously hit the ground running, and the focus on the connection between autism and foster care, I think, is really important. And obviously, Dr. Zena's in the trenches on that. But the question I have is about the strike teams that you mentioned and how they're spending a lot of time trying to wade through drug interactions. And I just wanted to make sure that you knew, and you probably already have access to this, there are robust computer programs that do that for you.
Okay.
And I just wanted to see if you guys had access to any of that. If not, I'd be happy to.
No, I would welcome any information that you have on that. We still would have to flesh out the proposal, so it'd be great to work with you on that.
Thank you.
Representative Hughley.
Thank you, Mr. Chairman. To Madam Commissioner, thank you for the work that you do. And just let me get a plug in for the Muskogee director. She always answers the phone. So, but this is a problem that we've had, and there've been a lot of staff changes. So every time we start working on it, then we get a new person and we have not gotten it resolved. For children with complex needs, as you say, that come into foster care and they are in small group homes and they enter our school systems. The school system is having difficulty with getting the education records because these children have needs that need to be addressed. It might be an individual education plan, or they may have some other challenges that the school really needs to know about. And our schools are telling us that the children arrive and they don't have ID on them. And sometimes they run away the first day at school and they can't help the police. So tell me how we can address this, or maybe we need to talk offline about how we can try and resolve this issue that we're having locally, because it creates a gap for the children in their learning. So I appreciate all that you all do.
So once I got to DFACS and DHS, one of the things I noticed that bothered me, I'm a Georgia Tech nerd, right, is the technology was not integrated with other state agencies' databases. So for example, we knew, or I discovered almost immediately, that we weren't automatically integrating like the child's medical records from DCH into our case management system. Caseworkers were actually typing in their diagnoses and their prescriptions, and like there were typos, it was outdated. But the same thing for school records, right? That we need to better integrate across our databases. And so one thing that we're already working on is it's a portal called the Community Portal. We haven't named it yet, but it's going to be a tool where if you're a foster family, you can log in and get on-demand information that you're entitled to under the law to better understand the child that you have. And the same thing, ideally for school officials, for any of our healthcare providers, congregate care providers, they'll have access to that system. And we're getting feedback from basically all the stakeholders we can engage right now to see what they want us to build into it, because it's fully customizable. So that's something that we have on our radar and we're working through.
Senator Payne.
Thank you, Mr. Chairman. Thank you, Commissioner. I have 30 years I worked with DJJ and placing kids, and the frustration throughout my 30 years was always, you get a kid, you do all this work to get them into a placement. And I know DFACs, I've had friends with DFACs and they were the same way. You get them into a placement and then they get removed from the placement because of behavioral issues. And it's so frustrating because you're thinking, well, you knew you weren't getting an angel. You'd be some kind of, so my question is with, what percentage of those kids that are being hoteled have been removed from a placement that they've already been assigned to?
All of them.
All of them.
They've exhausted every placement option available to them.
And then my second question is there not anything we can do contractual when we sign up with these placements that they have to jump through some hoops before they just decide to punt a kid? Because, in my 30 years, I used to tell people not one of these is worth punting.
So part of the enhanced provider rate that we're doing on case-by-case basis is we have this criteria built in, and we're doing this via contract. We're basically telling a provider, if you agree to take a child out of a hotel or an office and we pay you this enhanced rate and they meet this level of criteria, you cannot eject them for a minimum of 6 months. Cannot, unless it is a true emergency, and we will have to sign off on that. But not only that, if you have the emergency or you need to discharge them to a lower level of care, you have to identify the best placement for them. So we actually go through step down, and we don't have a child in the highest possible setting for their needs, just discharge to the lowest level and end up in a crisis situation. So we are building that into the contracts, and it seems to be working so far.
We are running low on time, but I'm still going to try to get to as many of the questions as we can. Representative Al Williams.
Thank you, Mr. Chairman. Very quickly, thank you for what you do. Tough job.
Thank you.
But my question is, especially with foster children, the biggest complaint I get in my area, and that's all over Southeast Georgia, is the poor reimbursement rate for dentists. And we're losing dentists. There are no new ones coming on board. I know that's a federal question, but we do have some input. What do you see moving forward?
So, all foster care children are on managed care Medicaid. They're all through one provider, a Mayor Group. And that contract is negotiated and managed by the Department of Community Health, which works closely with us to make sure that we're really maximizing the benefits available to our children. That includes medical benefit and, the dental benefit. One of the most common complaints we get about benefits is that it is really hard to find dental providers in certain areas. So, I think the good news is that Mayor Group is working closely with us to see what they can do to improve. All of them are facing this issue. It's an access issue statewide. The department is too, but the department's also working through just naturally these contracts are going to expire. I believe it's July 2024. So they're getting input on what has been working, what hasn't been working. And all of us are at the table talking about the challenges that we need to deal with as we work toward a future contract. That is one of them that's on the table.
Leader Burns.
Thank you, Mr. Chairman. Just a comment, Commissioner. Thank you for your wisdom, your team's wisdom, for recognizing Dr. Michelle Zena and the great work she does with children. That pilot program in the 12th, I'm sure will pay great dividends for our state as we deal with this problem with autism and how it impacts our children.
Thank you.
Thank you.
We're thrilled to do it.
Representative Buckner.
Thank you, Mr. Chairman. Thank you, Commissioner, for your energy and your eyes wide open approach. It's been needed. To follow up on Representative Hughley's comment about when children are transferred or moved, one of the things that we have been told is that some of the care providers are entering data into the system. I think it's called the SHINE system, but they are not allowed to have information back. If there was a way for that to be more of an exchange as you go through the process of redoing the computer system, it would be incredibly helpful to those providers.
That is going to be part of the community portal software that we have just, we're trying to finalize all of the contracting for. That way they can log in. We basically get DFACs out as much as we can of being the communicator, right? Have to get the records and give them to the people that ask. people can log in on demand and get what they're legally entitled to on the spot. And it's just a regular real-time update of what the child's situation is, any appointments coming up, school records, all of that is going to be in one place on demand.
Senator Davenport.
Thank you very much, Mr. Chairman. Commissioner, thank you for all that you do. Let me just, I had asked a question for the Commissioner of Juvenile Justice, because that's one of the contracts that you all have. And this mental health treatment facility and substance abuse, I understand that there are 60 plus beds and only 5 children. Now, the persons who, organizations who have been denied or contracts have been withdrawn, are you all going back and look at those? Because the number, I know you said that was 70 and it was down to 40 and it's back up, it's still alarming. And so can you kind of address that?
So I think I want to make sure I'm properly answering your question. So one thing that I've tried to do is regularly engage with all of our providers. We typically do that with Together Georgia, to be all in one spot. And so one of the things they've told us is, even just within our own agency, we'll kind of have sort of duplicative requirements or conflicting requirements of providers in terms of licensing and inspections. And they're also really burdensome, and maybe they don't carry the kind of safety value that we think that they do. So we're taking, a holistic approach to make sure if we've denied someone, we have a good reason for it. And it wasn't some kind of technicality that really just keeps a good provider out of our system.
Okay, very good.
Last question in the room, and certainly not least, the person who has possibly championed this the most, the chair lady in the House of this subcommittee, Chair Lady Dempsey.
Thank you so much. Commissioner, I just want to commend you. What a great job you've done this morning. You've
Thank
shown
you.
how hard you've worked.
Thank you.
You spoke earlier about the heart of those who work in DFACS, and yours is showing. So thank you for that. I want to let everybody know, I know there's so many questions in the room and in this space, but next week we'll have the House hearing, and then I know that'll be followed by Senate hearings. We want to leave you lots of time to be able to really address and talk about much of the work that you're doing. So
I'm
thank
happy
you.
to.
Commissioner, that wraps up the questions in the room. I do want to give you one final comment. Hope I don't put a target on your back when I say this from other commissioners, but this was possibly the most informative presentation that we have had. And I hope that others will take note of that.
Thank you.
I appreciate you augmenting your slides with comments because we could read the slides ourselves. The detail you provided, it showed not only your passion, but your compassion. And I want to say that too, because I know that you don't do that alone. I say that to the others in the room who helped put that presentation together. I hope our members didn't gloss over this. We are so often a reactive government. One of the things in this presentation that was striking to me was your focus. And again, I know, Commissioner, you take the credit for it, but I want to share the credit with the others in the room as well, on preventative services, whether it was preventing autism or moving to help solve autism issues, preventing abandonment, or preventing foster care altogether. And I thought that was a very healthy approach, and thank you for presenting that.
Thank you. I could not have known where to focus on what we needed to improve and hit the ground running if I hadn't have gotten the support that I've gotten from so many of you here. So thank you for that.
Commissioner, thank you so much. We've exhausted the time. We're going to move to the next presenter. Thank you again.
Next up, we have Department of Public Health, Commissioner Toomey. You're online, and we're bringing you up now.
Thank you so much. It's a pleasure to be here with you, although virtually. I can't promise you the most informative presentation, but it certainly will be a heartfelt presentation about what we've been doing in public health. As I was putting together the presentation, I was reminded by the fact that it was 2 years ago at the first presentation, budget presentation that I did for you, that I talked about the fact that we're just setting up.
Commissioner, if you'll hold on just one second. Members, I know there's a lot of interest in the previous presentation. If you don't mind, please taking your comments and conversations outside of the room. Thank you so much. I'm sorry, Commissioner. Thank you. Please proceed.
No, no problem. The setting up quarantine sites at the airport. At that time, we talked about what my predictions were for this pandemic. My predictions are obviously wrong. And so today I don't plan to make any predictions of when this will end or how it will end, but I want to give you at least initially a brief overview of where we are with the pandemic and what we can expect. And the fact that now at this time in Georgia, we have access not only to vaccination, but also to significant treatments available that we did not have before. And so with your permission, I'd like to spend a few minutes of the presentation on the viral status currently, particularly Omicron, because that's 100% of our cases right now, and then move on to the budget presentation. With your permission, Mr. Chairman.
Yes, ma'am, of course.
Let's just start with the first slide. I just want to remind everybody the somewhat unusual structure of public health compared to other state agencies. We have a state office in 18 public health districts. Those districts are state offices run by district health directors, so physicians, state physicians that work for me, but 159 county boards of health. Those are the county health departments, in the sense, the boots on the ground. But those boards of health are independent of the state, but overseen by the district health directors who have a dual role, both with the state office, but also with the local public health boards of health. And so we work as a team. And I think that the thing about the pandemic that is really demonstrated is how important it is for us in public health statewide to work together as a team, because that is how we will be able to work most effectively at the local level where services are actually delivered for the nearly 11 million Georgians. Next slide, please. You may be aware of our dashboard. This is something I check every day to look at our confirmed cases and how many antigen positive cases there are, as well as PCR positive cases. And we've had significant numbers of cases, over 2 million if you count PCR and antigen positive cases. Next slide. But this is the slide I wanted to really spend a little bit of time on, because the surges are, I think, what we have always been concerned about, not only about the impact on individual health, but also the impact on hospitals. And you can see that Delta was surging in the fall, and we saw significant impact on our hospitals at that time with the need for ventilators and ICU beds. Over Thanksgiving, I was informed of the emergence of the Omicron variant. This emerged in Southern Africa, and we saw it spread into the European countries. And so we knew it would be coming to the United States. We didn't know at what speed. And so we were preparing, and believe it or not, even on that very Thanksgiving weekend, I was calling around to staff in the lab to ensure that if it did come to Georgia, come to other states in the US, we'll be prepared to detect it and sequence it to identify it. But I think the rate of spread of this variant was something that I have never seen in 40 years of public health. I mean, that straight up line is not an epicurve. I mean, it's a rocket ship. And that has gone straight up in the US and in Georgia. We're now 90, well, more than 90, almost 100% of all our cases are this Omicron variant. Next slide. And I'm showing this to you because I've never seen anything spread how this quickly and this completely across the US and Georgia. The blue or the purple bar represents Omicron. And I remember vividly in the beginning of December when we had a few cases all in metro Atlanta area, and we'll just see what happens. And what we're seeing unfold is this extraordinary spread of this virus to initially all parts of Metro Atlanta, and now moving into the rural parts of Georgia. And so initially to North Georgia, now into South Georgia. And the rate of spread is such that we are working hard to ensure we have significant testing available in all locations that have to ramp up those testing services to ensure that people have access to this test regardless of where they live. Next slide. We are seeing increased outbreaks, and we recognize that this is due to Omicron. The good news, and I'll be talking a little bit more about that when I talk about hospitalizations, if there is good news about Omicron, even though the numbers are significantly higher than anything we've ever seen before, the variant itself appears to be less severe. And so that individuals who do become infected are often less sick or even asymptomatic. But they still can spread that virus. What we are seeing is that we are having significant numbers of hospitalizations, particularly in Metro Atlanta, but spreading out to now into rural Georgia. But the major challenge that we have in hospitalizations has to do with the availability of staff. And I'm sure Commissioner Nagel will be talking more about that. I don't want to steal her thunder about staffing for hospitals, but that has been a challenge with Omicron, less so than the availability of ventilators or other equipment for the sick individuals. Next slide. But so what you're seeing is the increase in hospitalizations due to Omicron, even though the percentage of individuals infected with Omicron are often not sick and do not require hospitalization. I think the take-home message here is even the individuals who are hospitalized are usually less sick, require less intensive services, but virtually the vast majority of individuals who are hospitalized are unvaccinated. And so although the vaccine and boosters do not fully protect you against acquiring Omicron, they do protect you against the serious outcomes. And so they're still, I think, important for us to consider as one of the many prevention measures we have available. Next slide, please. And this is looking at deaths. As you can see, the Delta variant, which is there from July, peaking up in October, really was a very deadly variant. And we had many, many, many people seriously ill and quite sick, and some of the highest death rate we've ever had. We're not seeing that with Omicron, at least not yet. And we hope that this is, deaths are a lagging indicator, we call that. And we are hoping that because we have availability of additional treatments, that this will not become a part of our future. What I do want to say is, I'm sure you're thinking, why, if this is so mild, why are we seeing even so many hospitalizations? The answer is, we are seeing more cases than we've ever seen in any other situation of this virus. Last week, we regularly had 25,000 cases a day. And so even if a very, very small percentage of those cases require hospitalizations, if you just do the numbers, that will equal a significant number of hospitalizations. And it's always a concern to us that hospitals are filled to capacity, and don't have sufficient capacity for other individuals who are ill. And one of the reasons why we're so proactive in trying to ensure we had adequate testing throughout the state, in a sense, to protect the hospital emergency rooms from being deluged with people who just wanted to be tested. And we, I think, have done a good job of that. It's clearly a challenge that all states are experiencing. Next slide, please. I just wanted to show you briefly the vaccination statistics. About 62% of Georgians have one dose and 54% are fully vaccinated. And I know that that's not as high as some states. I am very determined that we will continue to offer vaccination and to make it available through it as in an easy way as possible, including to multiple providers statewide, that it becomes part of routine care. Now children from the age of 5 to 11, as well as 12 to 15, are eligible for vaccination as well with the Pfizer vaccinations. Only the other vaccines are not yet approved for children. And again, this is something that parents may or may not make the choice to proceed with, but we are making the information available, trying to ensure that everybody has the information about the potential value of the vaccine and the boosters at this time. Next slide, please. I just wanted to remind everybody that boosters are actually very, very helpful, particularly in helping to fight this particular variant. And now the boosters are available 5 months after your primary series of both Pfizer, Moderna, and Janssen, which we knew as Johnson & Johnson, and is still available. Next slide, please. I wanted to also reflect on the fact that our vaccine providers are statewide. We have enrolled over 3,000 vaccine providers, but almost 3,000 are actually currently active. That means they are ordering currently vaccine, and they include everything from family medicine physicians, internal medicine physicians, OBGYNs, and pediatricians who have really, the family medicine and pediatrician physicians have really led the charge to try to identify opportunities to vaccinate children, but also hospitals, urgent care facilities, and also chain pharmacies in our independent pharmacies throughout Georgia. From my perspective, the way that I envision this pandemic ending is that vaccination for COVID will become part of routine care, not unlike flu vaccine becomes. And so that the vaccinations won't be taking part in special events or special outreach events that public health does, but will be part of the care that is provided by your physician when you go to the doctor's office or the urgent care facility or to the community health center. And so I'm very grateful for the support of physicians statewide and the medical groups who have been such an important part of our pandemic response. Next slide, please. I also wanted to mention that long-term care facilities were one of the first facilities where we offered vaccination, working in partnership with federal pharmacies or with the pharmacies that the facilities themselves had engaged. We have a very good percentage of residents and staff vaccinated with initial vaccines. Our booster doses may look like they're not adequate to you. We're still working on that and working with the Georgia Healthcare Association very intensively to try to encourage and offer resources to the long-term care facilities to ensure that they have access to the booster doses. But I was told yesterday by the Centers for Disease Control and Prevention that in fact, our percentage of boosters in these facilities is actually higher than the national average nationwide. So I think that reflects the fact that particularly those partnerships with the facilities themselves and the Georgia Healthcare Association has made a real difference. As it has, if you look at our vaccinations in jails and correctional facilities, where we have worked not only with the Department of Corrections, but also the Sheriff's Association to ensure that we have the capacity to offer vaccination and build those partnerships to this high-risk population. Next slide. I very briefly wanted to mention our testing sites have really had to ramp up to address the needs of Omicron. We recognized that the Omicron was going to require additional capacity, and we had test sites statewide. What we didn't anticipate was not only how quickly it would spread, the fact that so many of our staff, but our contract staff would themselves become infected. And so very early on, as we were beginning to ramp up our testing sites were short-staffed because our own staff and the staff who were doing the testing were themselves out with the virus. Because of that, we set up 12 surge sites, 3 of them mega sites here in the metro area. The most recent at Mercedes-Benz, which had been such a successful place for both vaccination and testing. And as of, I think as early as today, we're also going to be offering vaccination as well as testing there, because we have the capacity to do that there. So you can see we have statewide capacity for testing, are continuing to add additional staff and additional capacity statewide. Next slide. I'm sure that you're getting requests about where are the rapid tests, and we don't have access to as many rapid tests as we did last year. We had gotten literally millions of rapid tests from the federal government last year, but this year we're on our own, competing with not only other states, but also the federal government, who, as you know, is also distributing rapid tests. But we have actually distributed enormous number of rapid tests, over 1 million, to a large range of providers of all of our local health departments, because it's such an effective way to quickly test individuals when they come into the facilities, but also homeless shelters, also hospitals, mental health facilities, university systems, EMS and fire agencies. We know that there's a nationwide shortage right now, but we have really been fairly creative in reaching out to get additional test kits, not only working with the vendor, but also with some of our contractors to use some of theirs. And we received about 60,000 kits last week and 50,000 the previous week, and are distributing them. And we'll continue to try to purchase, even as covidtest.gov is up and running, and that our statewide population can get at least 4 home test kits from the federal government. Very quickly, because I know I don't want to shortchange the budget presentation. Next slide. I wanted to talk about our testing program and just ask your assistance with this. We have relatively few of our schools currently participating in our testing program, which is fully federally funded, which will cost nothing for the schools. And in fact, only a little over 100 schools are participating. In fact, I think it's about 4,000 schools in Georgia that are eligible. We pay the schools to be participating, and their really only requirement is to identify a location for us to test. But we can now, thanks to the fact that we reached out to CDC and requested permission to actually expand the capacity of our testing in schools and make it more broadly available to others in the community. We've gotten permission to really customize the testing in schools to what is needed in that community. So we can test symptomatic or asymptomatic children, teachers, staff, even spouses and family members of those individuals. We can broadly define people who are in touch or in contact with either students or staff. And I really hope that with your help and your encouragement and our continued reaching out to all the school superintendents, that we can get additional schools on board with this extraordinarily effective and free asset that we can provide to them. It can be rapid test, it can be PCR. And again, this won't happen without the parents' permission. But we see it as an opportunity to ensure that school athletics can continue and that schools can continue to stay open safely. I know I've told you this in past discussions with you. I am so committed to ensuring that schools continue to stay open to in-person learning. And this is one of the tools we have to ensure that that can happen. Next slide, please. The one big change since I last spoke with you is the availability of therapeutics. And for the most part, the therapeutics are available to non-hospitalized patients with mild to moderate COVID-19 who are at high risk for disease progression. So you're going to say, who's at high risk for disease progression? It's those who are immunocompromised. It's those who have other underlying chronic health conditions that may make them more at risk for complications. It may be older individuals because older individuals have had a more challenging time, even when vaccinated, with fighting off this virus. And so I wanted to just very briefly touch on the various monoclonal antibodies, which are antibodies not naturally made, not those coming from someone who's had COVID, but actually that are made in a laboratory to fight off the virus. And there were 3 monoclonal antibodies that were effective against Delta: Regenco, Bimedi, and Sotrovimab. The challenge to us now is that the only one that is effective currently against Omicron is Sotrovimab, and it's in very short supply. And so when you look at the allocation that we have, if you only get 1,000 doses a week and we're having 25,000 cases a day, the math just doesn't add up. Evusheld is a monoclonal, which I think is really extraordinarily important for individuals like those on chemotherapy or otherwise immunocompromised, who can receive, in addition, not to take the place of the vaccine, but in addition to a vaccine, to provide some additional pre-exposure prophylaxis. Remdesivir is an antiviral that some of you may remember that we used for hospitalized patients early in the pandemic. It does seem to be effective against Omicron and can be used as an intravenous treatment in the outpatient setting, but has to be given intravenously, so therefore needs an infusion center or a hospital to provide that. And it is more widely available than some of the Sotrovimab, the more effective and newer antibody, monoclonal antibody. And finally, we have 2 new oral antivirals. And I think this is important. If you think of the antivirals, think of something like Tamiflu. When you get if you get exposed to the flu or you get the flu, if you take Tamiflu early, shortly after you begin to develop symptoms, it will block or blunt the development of worse symptoms and potentially shorten your course of illness. And that's what these oral antivirals do. They have to be given early in the course of your infection, so within 5 days of symptom onset, but they lead to quicker recovery, not unlike what we see with flu treatment. Molnupiravir is something, a Merck drug, and Pavlovid is a Pfizer drug. Again, unfortunately, very short supply. The Merck drug, which is quite effective, I think we only got about 3,000 doses in the last allocation, which is every other week. And again, remember that if we're having 25,000 a day, we really have to focus on ensuring that we get these antivirals to the people who are most benefit and are most at risk for complications. Next slide, quickly. And then the other thing just to reinforce the fact that our treatment courses are relatively low. And at the current time, Bimedi, which was very effective against Delta, although in high supply, unfortunately, is not effective when you have 100% of your cases now of Omicron. Next slide. And there have been a lot of questions from you about where we are, where can you go to get your oral antivirals? And because of this is a federally acquired and federally distributed 2 drugs, we have worked at HHS direction through the federal pharmacies. So Walmart's, Walgreens, and the Good Neighbor Pharmacy Group, which you may recognize as a small independent pharmacies throughout rural Georgia. We looked at all the all the factors that may impact the need for these, including not only geography, but vaccination coverage and also underlying health conditions in these areas, and are trying to continue not only to onboard additional pharmacies, but also to try to secure additional medication as it becomes available from the federal government. We have no control over the allocation. It's fully federally allocated. And so it's still in short supply across the state, and we hope that we will get additional, not only additional doses, but additional pharmacies willing to distribute it. Not all pharmacies want to do it. We've been told that it's not worth, the effort. It's going to be, very labor intensive, and the reimbursement, the federal reimbursement is relatively low. But we will continue to work very diligently to ensure that we have a statewide access. And there is on our website, there is a map that has the current coverage of these therapeutics, both the monoclonal antibodies as well as the antivirals. And I always tell people, if you are looking to where you can go nearest your home, that's the best place to start. Next slide. And I just another vote of thanks to the many, many, many people and organizations and agencies who have been just extraordinary partners with public health in this response from the very beginning. Both Metro and Georgia Chamber, the Hispanic Chamber, ACCG, the Georgia Municipal Association, the Department of Economic Development put me in touch with multiple people with whom public health had never been partnering with, who allowed us to make PSAs that were extraordinarily effective in trying to encourage vaccination. A shout out to not only the Department of Agriculture, but the Georgia Poultry Association, who have been just key partners, both in reaching farm workers as well as the poultry industry, and clearly other state agencies, DCH in particular, who've been right with us from the very, very beginning, as well as all these other partners you see here, Latin American Association, NAACP, numerous medical associations and universities. One shout out to the Woodruff Association, the CDC Foundation, who have provided additional support through the Rollins School of Public Health for us to get additional staff for contact tracing, additional staff for epidemiology. That's the science of kind of identifying disease trends and counting them and identifying where we need to put our interventions. Without their help and the CDC Foundation's help, we would not have had sufficient capacity to respond as we did. And finally, also to the Blind Foundation, who was made available, not only Mercedes-Benz Stadium, but also has helped us with numerous PSAs. And that's really, next slide. I just wanted to close with this to remind everybody, isolation, when you're infected, is different than quarantine. When you're exposed but not yet infected. And we changed our isolation and quarantine guidelines to be in line with CDC's shortened isolation and quarantine requirements. We were actually moving in that direction even before CDC was, and I was so pleased that they basically followed our lead. And have done something similar for schools and daycare centers. And I think it's just extremely important. We now have 2 years of experience with this virus. We see how it spreads. We also recognize that we can't have people out of work. We can't have families who can't, put food on the table. That is not going to have healthy people in the state. And so we really have been working to ensure we have a balance that protects health. At the same time, we ensure that people can continue to go on with their lives. And these are some of the things that we've talked about, not just the vaccinations, but also wearing masks in settings, and hand washing, my favorite low-cost intervention. But these are some of the things that we've been working on now, and the updated isolation and quarantine guidelines, both for the public, for hospitals, for daycare centers, and for schools are on our website. And Mr. Chairman, I'd like to stop here just to see if there are any questions before I move on then to the budget.
Thank you, Commissioner. You don't have any, you have a few questions. Chairman Perkle, do you want to go ahead and go first?
Thank you, Mr. Chairman. A question I have before we get to some of those that are online. According to one of your slides, 62% of the population universe eligible for vaccines have received at least one dose, which I think that's pretty good. How does it look going forward? You said that it might become like part of the care that we do for flu, for example. Pre-pandemic versus what we're looking at now, what percentage would have received the flu vaccine before and now?
I don't have the exact numbers. I think probably relatively low numbers in the general population, high numbers in hospitals, because the healthcare workers, it's been extraordinarily important for healthcare workers to get the flu vaccine. The difference actually between the flu vaccine and COVID vaccine is the COVID vaccine is actually in some ways really quite effective. The flu vaccine changes from year to year and may not be a good match, but our COVID vaccine has been shown to really prevent deaths and hospitalizations very significantly. And it's hard to say. I can't predict what's going to happen with Omicron or any future variants, but it would not surprise me that in the future, that as we move forward, there may be a vaccination that's a combination of flu and COVID that you can get annually as a kind of COVID flu booster. But I think we have to see how this unfolds. I think we haven't seen the end of Omicron yet. It looks like it's coming down, but I think it's too early to say. I think by the end of the month, certainly. But the jury's out on what the final verdict will be on that.
Thank you for that. And the point I was trying to make or to get at is that we've had the flu vaccine for many, many years, and it changes each year. But we have a system where, my mama will remind me, have you had your flu vaccine yet? And no, ma'am, I hadn't, but I'm fixing to go. And I have had the flu vaccine, but 62% for a very effective COVID vaccine would be with a higher rate than what we normally do with a flu vaccine, I would think.
But you actually need to have more than one dose. I'd say to be highly effective would be increasing not only our second dose, but also boosters. Because one dose would not be sufficient, I don't believe, to provide the kind of protection that you need to something that has proven to be so potentially dangerous. But I agree, we're doing better than many of our neighboring states. And I am very committed to continuing our efforts to reach everyone. And it's going to, I think, require that partnership with all of the medical providers and to continue reminding people of the availability of the vaccine, the safety of the vaccine, and making it available through routine care as well as local pharmacies.
Thank you, Dr. Tomey. Speaking of trying to get it out to everyone, Representative Bruce had mentioned online, there are people living in tents along the highways and other places. Is anything being done to get vaccines to these people?
Yes, and testing. I mean, we have worked very diligently to address issues of the pandemic among the homeless. Fulton County in particular has been proactive in that area. And we also have a hotel, which we have put in place to provide isolation and quarantine availability for those individuals who may test positive or be exposed, to get them off the street, but also to put them in a residence that will be safe for them to get through this infection. But there's been a lot of work proactively to identify those individuals and get them vaccination and testing as needed.
Okay, additionally, Representative Anulowicz asks, I'm baffled that more school districts aren't taking advantage of the testing program. What kind of feedback have you gotten from districts that declined to participate?
I think there's a concern among parents that maybe they don't want to know about the status. But we have worked so hard to change our guidelines to keep kids in school that I think that the requirements for 14 days of quarantine, sequentially keeping kids out of school, really for just prolonged periods of time is not the way that our guidelines currently read. And so I think now making this parents aware of this, making the school superintendents aware of this, working with the Department of Education. And I have personally sent letters out to all the superintendents statewide to remind them of the availability of this. And I would ask that when you go home to your home districts, to please talk to your principals. I know how closely you work with the schools in your districts, to how important this could be and what a great adjunct this is to testing in the community. And it's now open so broadly, it would be an asset to all staff and family members and others who even touch in some way the schools and the children. I don't understand it either, but we want to keep making people aware of it.
Mr. Chairman, I'm gonna grab some of the ones in the room first, if that's okay. Senator Davenport.
Thank you very much, Mr. Chairman. Dr. Toomey, thank you so much for all that you do. I call the health department all the time and get results. But a couple of things in Clayton County, the quarantine there at, I guess, the Jameson, that group of people that were brought from Atlanta to Clayton County, and the school system did not know they were coming, but all the people had COVID and were placed there. And then the county commission chair did not know they were coming, and now I understand that there are not funds, or there are not things, they're necessary services. And so can you comment on that and see if that would be addressed? And the other thing, you know, every time the legislative delegation is on a call or Zoom with the leaders of the county, it's always a question about these 18 districts, and will Clayton County be an entity by itself, or will Clayton County still be with the LaGrange area and the district? So if you can address those two issues. I know every time I call the health department, you all feel that I feel that I'm the only legislator that you have to address, but thank you for helping us. And I've made it a commitment to make sure that people in the district and in the surrounding areas are vaccinated. I'm very fortunate because we have the former U.S. Surgeon General and former director of the CDC, Dr. David Satcher, who's also a former president of 2 medical schools, to get on calls and to say that it is important to take the vaccine. So the end of this month and every month, I will be with the health department, with churches in my area giving the vaccine. So if you could just comment on those two things for me.
No, thank you. And in answer to your first question, we do have wraparound services. I understand, and I was informed that that contract was signed, that we didn't proactively alert the county commissioners. I wasn't aware of that, although I have to say we had similar hotels elsewhere and haven't done that. So I think we were very anxious to find a location that we could work with. And there are services to provide the support services for them and ensure safety and ensure the separation of the other people in the hotel. And I'll be happy to talk more with more specifics about that with you and our team. In answer to your question about, I think it was 2 years ago, I talked about in the budget reductions that we were going to reduce the number of districts to 17 to combine Clayton with the LaGrange district to create a mega district that might be more efficient and would allow us to serve more people. I think given the pandemic and the challenges of both recruiting and ensuring that we have the capacity to serve everyone at this time, we've realized that that's just not feasible. And so we are moving forward right now to try to hire a health director for Clayton and a health director for LaGrange, so two separated, maintaining 18 health districts. And I do want to give a shout out to Dr. Townsend. Beverly Townsend is an extraordinary public health leader who has served as acting health director in both those districts, stands ready to answer all your questions and serve you. And I know many of you in the room know her, and she's done a superb job, as has Carly Heath, in running the health department. So, but to reassure you that we are moving forward and have the position advertised and are actually reviewing resumes right now.
Dr. Toomey, if it's okay, we have several other questions, but I know that we have only 1/6 of your time remaining as scheduled. If it's okay, can we go ahead and move to your budget presentation and do those quickly? And I'll ask those other members if they don't mind to follow up with you either offline or in subcommittee.
No, that'd be perfect. And I'll be very fast because I'm
Thank you.
very excited about the budget that the governor has proposed. And let me just first start with the first slide, just to remind everybody about our expenses. The majority, 65% of our budget is actually direct services. So that includes everything in like WIC. It also includes the grant and aided counties. Many of the contractual services are also services to people. So the relatively small amount of our expenses go to personal services or to staff. And so that's makes us a little different than some state agencies. Next slide, please. But the other thing to bear in mind, and this is not looking at COVID. COVID's a whole different animal, and I can give you a whole hour-long briefing on COVID alone. About 60% of our total funding is our federal funds. So that includes WIC. It includes things like our HIV, not only our treatment programs, but also our CDC-funded programs that include HIV prevention as well as tobacco and chronic disease prevention. So environmental health, STD, TB. So that's really largely federally funded. Our state funds, about 40% of our budget, more than half of those state funds go to in grant and aid to the counties. So much of our state budget really does support the county boards of health. And I think that's important to remind everyone, is that they really are the foundation of the work we do on the ground. And much of our state budget goes to their support. Next slide, please. I am very pleased that the governor has recommended a statewide change and a pay increase for staff. It'll be 29 million for us this year, and then next year increasing to 40 million. I'll break that down for you in the next slide, in addition to the other enhancements. I can't tell you, go to the next slide, please, how much this means to our public health staff. I think some of you know from your work in your home counties, but it has been a long 2 years, public health. And our staff from the state, district, and local levels have worked tirelessly to protect the state, often under very difficult circumstances, working nights, working weekends, working holidays. And, you know, I think it's well known that our salaries in public health are not on the scale of other state agencies, even around us and in the other southern states, let alone we also compete with other public health agencies here in Atlanta, for example. And I can't tell you how many people I've trained only to have them go to CDC with an extraordinary increase in salary, but we lost one of our epidemiologists to a school district because they were able to pay more. And when you look at this list of the programs that will be impacted by the pay increase, and it's just really to me a relief to see this here, because and particularly shouting out epidemiology, immunization, the environmental health inspectors have been a key part of all of our work on COVID, the nurses who are providing the vaccinations and tests. This will give them a little bit of added boost, and I hope, can help us recruit and retain these important staff who have done so much, really dedicated their professional lives to protecting the health and lives of Georgians statewide. Next, I wanted to introduce the Comprehensive Care Management High-Risk Pregnancy Pilot Program, which is an AU program. It was thought to be an effective pilot, and they would like to roll that out statewide in partnership with us. It allows text messaging to identify any problems in prenatally. The idea is to identify individuals at risk for hypertension, preeclampsia, other pregnancy or postpartum issues that may lead to maternal mortality. And I'd like to say this, coupled with our continued work with the perinatal centers, and a shout out to Commissioner Noggle and the increase in Medicaid expansion for pregnant women to a year will again provide a comprehensive approach to preventing not only maternal mortality, but also the high infant morbidity and mortality we have here in Georgia. The Georgia Coordinating Center through this budget will be fully funded. And just to remind you what this coordinating center was, right before the pandemic, I think it was December before the pandemic started, Grady had a massive flood that incapacitated a large number of their floors. And so there was not the full capacity in the metro area for hospital beds. And so we needed to set up a system to ensure that the EMS providers could go to a hospital that could manage the individual, whether it was trauma, stroke, or some other health condition. And at that point, the regional coordinating center was set up to manage this in the metro area, and that was funded through your support. But we recognized once COVID happened, and we needed a similar coordinating system to identify hospital capacity for individuals with COVID and where there was availability of ventilators and ICU beds, and to appropriately direct the EMS agencies. And so we recognize that a statewide implementation of this coordination would be absolutely essential to truly be able to respond to the pandemic, as we're seeing right now the hospitalizations increase in rural Georgia, even as we speak, because of the Omicron. So this is this fully funds our statewide expansion of the Georgia Coordinating Center, which will be a partnership with all hospitals and centered here in Metro, but will provide statewide coverage. And it's really, I think, a much needed asset to our healthcare system. Our FMAP adjustment is included in our FY23 budget. And to close, the final issues I wanted to bring up is the addition of $9.9 million to the AIDS Drug Assistance Program. The AIDS Drug Assistance Program provides drugs and also can do insurance continuation for individuals with HIV to ensure that they are on treatment. Treatment is absolutely critical. Treatment is prevention for individuals with HIV, because it actually stops any further transmission. The South has the highest rates of HIV. In Georgia, unfortunately, both rural and metro Atlanta have the highest rates of HIV in the South. And so we have been quite improved in our outreach because a Trump administration program called the End the HIV Epidemic, the EHE CDC funded program, gave us additional funding for outreach to identify individuals with HIV infection, but we didn't have the capacity to link them to care immediately and to have sufficient funding for care. And we were at the point this year, which would have been a public health tragedy, in my opinion, to have to start a wait list for people with HIV infection. And that's, inadequate for the community, but also inadequate for obviously the individuals involved. And this $9.9 million, both FY 2022 and 2023 will ensure not only full funding, but provide our full state required match for the federal government to allow us to increase capacity, even as we streamline and ensure improvements in the program. So this is, to me, one of the really most important items in our budget. And the last item is a $45,709 add in FY 2023. This is for the pre-exposure prophylaxis program. PrEP is a medication that you give to individuals who may be at risk for developing HIV and prevents the acquisition, so it prevents the infection from happening. The two counties where the PrEP program was rolled out, this rural PrEP program, Haralson and Towns, were identified because they were the counties with high risk for HIV that may be acquired from IV drug use. Unfortunately, because of COVID, much of the initial work had to be set aside as staff were redeployed to COVID-related interventions. So we're back starting to ramp that up, including developing partnerships with Brunel and other community-based organizations, particularly in towns, to be able to ensure that we can reach as many at-risk individuals as we can with this PrEP pilot. The idea here was to develop a pilot program for how to do PrEP in rural areas, because it's different than doing it in metro. And I can tell you that we have very good PrEP programs in many of our metro health departments, but really had not developed them in many of our rural areas. And we're hoping that this pilot, once fully funded and fully implemented, will serve as the prototype for what we can do throughout the state of Georgia. And that's our full budget. And thank you so much. I'm sorry I ran over a little bit, even talking fast.
Thank you, Dr. Toomey. I would ask, I know there's a lot of questions. I would ask that the questions, because of time, be devoted to the budget. So if you have policy questions, please follow up with the commissioner and with Dr. Toomey offline. I'm going to give a few seconds for folks to hit their buttons if they want to take their questions off if they aren't policy related. If they aren't budget related. Okay, we do have a couple of budget related ones. Representative Matt Dollar.
Thank you, Chairman. Thank you, Dr. Toomey, for that very thorough, great presentation. I wanted to touch on the HIV treatment funds that you referenced. Given that Georgia has one of the highest rates in the country, as you said, in your opinion, are we doing everything that we can be doing, given the new funding, to address this issue? Because, as you said, treatment is prevention, and this will, one, help the patients and further help the state from a cost perspective.
No, thank you. And I think many of the other things that we're doing in partnership with the medical community is to ensure that all providers statewide understand the importance of PrEP and offer PrEP, and also understand the way HIV treatment can be rolled out to individuals and can be managed in a primary care setting. It doesn't require an infectious disease physician to manage an individual with HIV infection. I think that much of our HIV prevention activities, with the exclusion of PrEP, because we can't use CDC funds for PrEP, but have been from the Centers for Disease Control Prevention. And a lot of that is focused on outreach and then and testing. And once testing occurs, to try to identify those individuals who may benefit the most from PrEP and refer them there, and those who may benefit from the treatment as well if they are infected. But remember that we are the payer of last resort, and the insurance will cover these treatments. So we're trying to, with this addition, to ensure we cover all those individuals that fall into our catchment group, but we cannot possibly, with this amount of money, provide treatment for everybody. And so there will still be a large number of individuals insured who we hope will access it. And again, that's going to require us to work in partnership with other providers statewide.
Thank you, Dr. Toomey. I have a few questions on budget matters specifically that I just want to ask you to please follow up with the subcommittee on. One, last year, I know we did some funding for your computer system, online scheduling of vaccinations. If you don't mind giving the subcommittee an update on that, if those monies were used and where we stand. We also did some emergency funding for a GRITS update. I don't know where we stand on that, but if you wouldn't mind following up with that on the subcommittee. And also, I know we did emergency funding for the ADAP program then. I'm going to be curious about whether we have resolved our cash flow and financing issues there so that that's not an issue going forward, but please feel free to take those up for the sake of time with the subcommittee.
Yes, and it is. I think that this, both program management structure and this particular ad reflects all those changes that you had requested.
Thank you so much again for your time. And I don't think we have any other budget questions. Thank you again for what you're doing for Georgians. Have a great day. Our next presenter will be the Commissioner of the Department of Public Health, Commissioner Kaylee Noggle. Community Health, sorry. Hey, Commissioner, welcome to the podium, and the floor is yours.
Thank you, Chairman Tillery. I was about to say I've had a lot of job titles over the last 2 years, but public health is not yet one of them, at least not commissioner. Good morning again, Chairman Tillery, Chairman Perkle, members of the committee. Thank you so much for the opportunity to be with you this morning. Again, my name is Kaylee Noggle. I have had the pleasure of working with so many of you over the past few years in a number of different roles, and I am pleased to be with you and before you again today as the Commissioner of the Department of Community Health. Many of you also know Ryan Loke, who joins me today. He's probably in the back corner as DCH's Deputy Commissioner and Chief Health Policy Officer. He and I had the privilege of working very closely with former Commissioner Berry and the entire DCH team during the early days of the pandemic, and over the past 2 years as we focused on Governor Kemp's COVID-19 operational response. And I'm thrilled he joined me in this new venture again as well. Also joining me today is Rich Kim, our interim budget director, Brandy Sylvan, our director of government relations, and also Caitlin Ward of our team as well. In terms of our leadership team, thanks to your generous funding and our budget in FY22 to support our expanded capabilities, we've been able to add several new staff members in new or expanded roles, including a new chief compliance officer, a new technology officer, a finance advisor, and I've been able to ask a few others to stay on with us, including our chief of staff and Joe Hood, with whom many of you have worked over the years. Our team's nearly complete at this point, but we're still recruiting for several key positions in both our legal and finance teams. As you know, DCH provides healthcare services to nearly 1 in 4 Georgians through both our Medicaid and state health benefit plan programs. And our FY23 budget will account for nearly 30% of the overall state budget. Because of this, we know it's critical for us to better understand how we use those funds, what we're getting for those dollars, and how we can better utilize our resources to further our mission of providing quality healthcare access and healthcare outcomes to Georgians. I hope you'll soon recognize how our renewed focus on quality, accountability, and transparency results in improved day-to-day operations of the agency, as well as an improvement in our ability to offer you sound policy recommendations and data-informed, actionable insights to support our mission. We know that our ability to make timely payments to our providers is critical, as is our ability to execute contracts and to resolve membership issues. We're working to identify and resolve those bottlenecks, but also working to identify our internal talents and untapped resources. We look forward to discussing more of that work with you in the coming days. Today, I'll share a few agency highlights, take a look at a few Medicaid and SHBP trends, and then review the governor's budget recommendations for the amended 22 and FY23 budgets. First, a few agency highlights. In August, we launched our first public-facing care management organization, Quality Performance Dashboard, that publishes the CMO's performance achievements in relation to our stated performance goals for review by both Medicaid members and the general public. In FY21, our Inspector General Office identified over 5,000 cases of fraud. And since then, we've piloted and implemented a new artificial intelligence tool that will detect abnormal Medicaid billing practices so that we can identify those potential cases sooner and more effectively. In July, we submitted our home and community-based services plan to CMS for review, which includes a 10% provider rate increase. We've continued the work of our psychiatric residential treatment facility working group, resulting in a rate increase and policy alignments between CMOs, but we know that our work there is not done. And that rate increase is just a first step. Chairman Tillery, we're thankful for your leadership and efforts to advance this work, supporting Georgia's most vulnerable youth and this important component in the continuum of care. We look forward to working with you and members of the House to continue moving forward priorities related to mental health, treatment, and parity during this session. Also, special thanks to our sister health agencies, as well as numerous advocates that have partnered in this work with us, including Voices for Georgia's Children, led by Dr. Erica Sidkoff. We also continued this year to provide staffing augmentation around the state in response to the COVID-19 pandemic and staffing shortages. In fact, in this last round of funding, about $100 million, Governor Kemp mentioned, we were able to actually authorize some additional staff for the PRTFs to ensure that some of those beds remain online. To date, that funding totals over $755 million. And finally, we've also approved 42 certificate of need exemption requests related to the COVID-19 pandemic so that we're ensuring our healthcare facilities continue to maintain their capabilities to respond to the pandemic. As an overview and a reminder, our FY22 budget includes $3.9 billion in state funds spread across our programs of low-income Medicaid, our age, blind, and disabled, or ABD Medicaid program, Peach Care, and several other departmental units. 97% of our budget is expensed through Medicaid and benefits. On the next few slides, I'll highlight some Medicaid trends we've seen over the past few years. Overall, in Medicaid, we saw a sharp increase in enrollment since the beginning of the federal public health emergency, resulting in an 11% average member growth in FY21 alone. And as you know, all Medicaid members will remain eligible for benefits until the end of the federal public health declaration. This has also obviously driven up our costs as well. This next slide illustrates the distribution of our Medicaid members between our programs. 70% of Medicaid members are in the low-income Medicaid program, 23% in ABD, and just under 7% in Peach Care. However, in terms of expenditures, the age, blind, and disabled population accounts for more than half of our total Medicaid expenditures. We've also begun looking at Medicaid cost drivers over the past few months so that we better understand where our funds are going. In FY21, the ABD program saw a net $5 million reduction in claims, largely due to a reduction in enrollment of 2.8% and a decrease in nursing facility expenditures by 9%, but price increased by 7%. On the low income side, expenses, as you know, consist of capitation payment rates to our 3 CMOs. In FY21, net claims increased by $261 million or 7%, while enrollment increased by 13%. Key takeaway from these few slides is that yes, expenses are up, driven both by enrollment, but also in the cost of services being delivered. In the state health benefit plan, we're seeing similar trends. Growth in expenses dropped sharply in FY20 due to a reduction in utilization of services during the early part of the pandemic. But as you can see in 2021, utilization and cost have quickly rebounded, resulting in a 14% expenditure growth in FY21. This slide depicts the overall financial status of SHBP, with these lines representing our revenues in blue, expenses in red, operating reserve in orange, and the balance of our OPEB trust funds in purple. As you can see, expenses are outpacing revenues. Though we're currently analyzing the positive revenue impact of a one-time budget add that we'll discuss in a few moments, as well as the positive impact of the statewide COLA proposed for FY23, and we'll be happy to share those impacts with you in the coming days. I'll move into the governor's budget recommendation for amended 22. My staff has warned me not to share as much detail as I normally would like to for time, so that we leave time for questions, but trust that I look forward to diving into those details with you during subcommittees. I also have to say that the amended FY22 and FY23 budget proposal by the governor represents one of the strongest budgets for this department in many, many years. And for that, we're very thankful. I'll start with the statewide changes. We've summarized those across programs for both years for the agency. I know you've heard of a lot about those from all the agencies. I will echo what you've heard from so many others this week, but we are incredibly thankful to Governor Kemp and his recommendation to provide a $5,000 pay increase in amended 22 and a COLA, as well as additional leave and ERS benefits and flexibilities in FY23. These will go a long way in addressing the staffing challenges you've heard so much about and that we've certainly been impacted by over the last several years as well. So thank you. Next are Medicaid changes, many of which are annual changes. So I'll just hit the highlights. These are routine. You hear about these year in and year out. First is growth to meet projected need. Again, that public health emergency, the longer it goes, the more members that we're going to keep on the rolls. It's $263 million in the amended budget, mostly in the low-income Medicaid program. The second line is FMAP, total savings of $272 million. The longer that public health increases, the longer that we are available to draw down a higher federal reimbursement rate, which reduces our need for state funding there. The Part D clawback and Medicare Part B premiums are routine true-ups, representing a $14.8 million reduction and a $6.5 million increase respectively, and a $2.7 million true-up in the Indigent Care Trust Fund for the state match for dish payments. The last three items are newer. The first is $1 million for clinical trials coverage. CMS issued new guidance to state Medicaid agencies in December, instructing us to begin covering routine patient care costs associated with the participation in an approved clinical trial, effective in January. So this $1 million will support that increased coverage, and you'll see that again in FY23 as well. Additionally, there's $447,000 for coverage, Medicaid coverage of donor breast milk. One of the first meetings I had when I joined DCH over the summer was with the Georgia chapter of the American Academy of Pediatrics regarding the benefits that donor breast milk has for very low birth weight newborns, including both saving lives and reducing longer-term costs. We moved forward and implemented that change immediately over the summer, and I'm pleased that the governor has chosen to continue to support this item in his budget. Finally, there's a reduction in savings of $179 million from the Age Blind and Disabled program that is reflected as a transfer, a one-time infusion into the state health benefit plan. Other changes in amended FY22 are largely in the department admin program. $3.5 million for our claims processing system, or what's called an MMIS, which has a portion of its contract cost tied to membership. So as our membership in Medicaid rises, this contract cost rises as well. $290,000 for DCH's work in conjunction with OPB and the Office of Health Strategy and Coordination and the Office of the Commission of Insurance to support the governor's 1332 Georgia Access work. $6.7 million for our MEST, or Medicaid Enterprise System Transformation Project. This is a technology and infrastructure project that will replace several of our existing systems with a new modular system as required by CMS in order for us to continue receiving enhanced federal cost share. These funds will support the implementation of the system integrator and the first two modules, and then full implementation is expected sometime in 2025, at which time we'll retire the legacy system, and actually we're hoping to end up saving some funds in the long run. Next is $2.8 million for the all payer claims database, which is now being led by the Office of Health Strategy and Coordination and OPB. And $424,000 for a project called EASE, or our Enterprise Analytics Solution. This is also part of that MEST project. It's essentially going to bring all of our data warehouse, architecture, infrastructure, and reporting and analytics in-house instead of being housed at disparate external vendors, so that we can provide more robust, timely, and insightful data and data visualizations as we make business decisions. And then finally, there's a reflection in the state health benefit plan program of bringing in the transfer from ABD of $179 million as a one-time cash infusion. Moving into the FY23, we'll see a lot of those standard Medicaid changes again. So we'll keep them at a high level for today. But growth, again, based on need, is $49.9 million across all of our programs. $149 million in FMAP to replace the loss of the enhanced FMAP that's currently in place during the public health emergency. That's planning for an eventual end to that, in which we'd have to replace those state funds that were removed from the budget in prior years. Next is an increase of $87 million to reflect the annual adjustment in our FMAP rate. Our current rate from CMS that's been shared, we're currently at 66.85. That's going to adjust down to 66.02, which will require a little bit additional state funding. A similar change and adjustment for our FMAP rate, going from 76.8 to 76.21. Again, Part D clawback, an increase of 15 million in ABD and 10 million again in Medicare Part B premiums. In the Indigent Care Trust Fund, there's an additional 15.8 million used as, again, a state match to draw down additional DISH funds for our private hospitals. And then the annualization of the cost for clinical trials and donor breast milk. There's also a couple of yes items in our budget in both years, which just trues up fund sources to available funds. Excuse me. The next few items reflect the leadership of Governor Kemp, House and Senate leadership, and many of you. These are really significant changes that are going to help us provide continued access to healthcare over the next year. And FY21 Chairman Burke led the effort to make Georgia one of the first states to provide 6 months of Medicaid coverage to postpartum mothers. And as you've heard, we continue to work on overall maternal and infant mortality rates in Georgia. The governor is now recommending this $28 million in our budget to extend that coverage to a full year. House Bill 163 was championed by Chairman Cooper in 2021 and provides for, quote, express lane eligibility to automate enrollment into Medicaid for youth already receiving SNAP or TANF benefits. And this $39 million will support those increased health benefits. There's $85 million to eliminate an issue that many of us have talked about for a number of years called attestation. This funding will standardize and normalize rates for 108 procedure codes for all providers moving forward, regardless of their prior attestation status, completely eliminating that issue, which is amazing. Next is $11 million for Therapeutics services, which is an expansion of behavioral support aid hours for behavioral health, autism, and medical providers serving our most vulnerable and high needs youth. A therapeutic foster care program model was introduced in DFACS's budget for FY22, and this additional funding will allow us to expand that model to the entire youth and all of Medicaid population. There's an additional $1.5 million to fund 5 additional psychiatric and behavioral healthcare management services for patients receiving community mental health services as a result of recommendations from the Behavioral Health Reform and Innovation Commission. And lastly, there's a small reduction of $638,000, which reflects an adjustment to the 2019 RS Means Index related to construction and facilities improvements in our nursing homes. In total, the governor's recommendation increases our state funds in Amended 22 by $6.2 million in Amended and $507 million in FY23, bringing our total state funds in the amended year to $3.9 billion, $4.4 billion in FY23, representing nearly $18 billion in total funds across each program year. Chairman Tillery, Chairman Perkle, thanks to your teams, the House and Senate budget offices. We look forward to working with them over the coming weeks to further review these numbers. We're happy to answer any questions you or members of the committee have for me or any one of the staff that's here today.
Thank you, Commissioner. Thank you for leaving time for questions as well. We do have a couple of questions. I think the first one is Representative Knight.
Thank you, Mr. Chairman and Commissioner. I'm glad to see you there. I know we've worked with you in different roles, and I really appreciate your attention to detail. I like your opening comment about data and transparency. And I know, again, you guys, it's very evident that y'all are talking about your renewed focus on access, on quality of care, and transparency, especially within our managed Medicaid parts of Georgia. My question is, and I've got a couple of questions, but my first question is related to In the current managed care contracts, I know there are provisions that seek to provide a different level of payment for both the CMOs and the providers. And I think it's called a value-based purchasing concept. And that happens if certain quality improvement targets are met. Can you give us an update on those metrics? Are the CMOs, or in fact, if the CMOs are in fact splitting those payments with Georgia's healthcare providers who are really at the front line providing the healthcare as the contract requires?
Sure. Thank you for the question, Chairman Knight, and for your comments. You're correct. The current contracts provide for an option for us to use a concept called value-based purchasing, where we would essentially withhold a percentage of the payments we make to those CMOs contingent upon them meeting certain performance standards. There are federal CMS requirements that have to be met in order for us to do that. And we've been able to do it so far in just one of our contracts, the Georgia Families 360 contract. And it has to do with how much we're paying our CMOs. CMS would require that the rates that we pay the care management organizations be actuarially sound, something you know about, without assuming that they would not meet those. They still have to be projected to cover reasonable costs. We are currently paying our management care organizations on the lower end of that scale. So there's only one contract where we currently have the flexibility to do that withhold. We've run some numbers on what that would potentially look like to be able to implement that in the other contracts. We're happy to share that with you. In terms of the Georgia Families 360 contract, where we have implemented that, those are good questions. You know, we did take a look at what those performance metrics were and how that CMO has progressed towards meeting them. And quite frankly, they were meeting them every year, which to me suggests that we didn't have the right metrics in place. And so those were and are in the process of being revamped. We've gone from, I think, 19 or 20 metrics down to about 5, which align with our overall state quality strategy and are in line with the things that we're working on and are implementing those revamped measures this year. The other thing I'll say is that, to your point about how those payments are being paid out, and what I mentioned in a little bit in my opening remarks is we know that contract management and oversight is something that the department needs to do better at. The biggest way that we provide services to Georgia citizens is through our purchasing power, through vendors and contracts. We've asked use some additional resources and retooled some positions to increase our ability to do that by bringing in some external folks to actually hold and to do some further analysis on hear what the contract standards and SLA say, and then compare that to the performance reports that the CMOs are required to submit to us monthly, quarterly, and annually. And we're going to start publishing those. We think that those will be up and available kind of at a first round draft later this spring. We'll be happy to talk with you when those become available.
Senator Watson.
There we go. Thank you. Thanks, Chairman. Appreciate you being here. I certainly is music to my ears about hearing us using quality parameters, and because as quality is driven, so is price. And we're always sensitive to that, and we're certainly here at a budget hearing. I just wanted to follow up on the 1 year postpartum and the attestation statements. I presume that is both of those items, they're in this budget, and that will be go forward in the future relating to both of those?
My assumption is yes. The way that they're funded currently in the 23 budget is that they would be in our base budget. And so we would continue those year after year unless there's a change to our budget.
Thank you.
Representative Smith.
Thank you. My seatmate and I were visiting. Thank you, Commissioner. That was an excellent report to our committee.
Okay.
For the layperson listening to your presentation, I'm going to see if I can say the word correctly, attestation. Can you go into a little bit more detail of why it's fixed, why it can now be eliminated?
Absolutely. So attestation was a concept introduced back in 23 and 2014 as part of some federal legislation that would, the feds provided some enhanced funding for these 108 procedure codes for physicians and providers that actually made a physical attestation that they met the qualifications to receive those funds. Fed funding ended around 2015. But the state chose to continue those enhanced payment rates for those 108 procedure codes to those physicians that had attested to their eligibility during that time period. It did not allow new providers coming in or anyone that had failed to attest at the time to access those enhanced rates. So we've had a disparate system of payment for a number of providers over the years. This $85 million will fix that going forward. We think there's about 9,000 provider locations that will benefit from this enhanced rate and standardization going forward. So it's significant. You're welcome.
And sometimes it was as simple as they moved their office a block down the street and it pushed them out of attestation. So glad that the state has the funds right now. I think it's a good government move. $85 million though was hard to do during other years. Thank you, Representative Smith. Senator Lucas.
Commissioner. Thank you, Mr. Chairman. Commissioner, what are your plans when you get a call early in the morning that one of the rural hospitals cannot meet their obligation?
I'm sorry, that they cannot what?
Can't meet their obligations.
You know, I've had a couple of those conversations. And we're continuing to look at what we can do and how we can get ahead of that curve. And so that hopefully avert them from crisis before we get that phone call. I think we've continued to support flexibilities around telehealth. We continue to be supportive and thankful of the Rural Hospitalization Stabilization Grant Committee and funding to go to that. And hopefully the better we get at making timely payments and making sure that we're not the reason, that they're not waiting on funds from us, that it improves their cash flow position and averts some of those issues. But we're always open to working with you on new ideas and certainly appreciate the relationships we have with others that help us kind of stay abreast of some of those issues.
Chairman Knight.
Thank you, Mr. Chairman. I had a follow-up and I apologize, but this may dovetail into some of the policies. Dr. Toomey had talked about the vaccine and quite frankly, the availability of the vaccine all over Georgia. So we've got access. Particularly, talking about the chain pharmacies and the independent pharmacies. It is my understanding from some constituents that have contacted me is that in some of the Medicaid, the CMO managed Medicaid programs, that the independent pharmacies, when they go to give these vaccines, that the patient is being told that they must go to a chain pharmacy to get the vaccine. Are you aware of this? And again, this goes back to access, steering, some of the things that this General Assembly has really focused on to make sure we provide quality access everywhere.
Sure, I'm not aware of that specific issue. We certainly echo and hear your comments and sentiments around steering. And again, that goes back to how we're holding our CMOs feet to the fire in terms of their contract arrangements, and we'll continue to do that. We'll be happy to look into that specific issue. And if you have examples, we'll take them from you and go take a look.
Representative Donahue.
I just want to thank you. We had a great relationship with Commissioner Frank Berry. He was always transparent. And anytime I needed anything, it was amazing, the transparency. And thank you for continuing that legacy. And I just wanted to bring that out, that you're doing an excellent job, and thank you very much.
Thank you so much.
Senator Lucas.
Yeah, Commissioner, what I wanted to ask you, there's been some question about advanced dish payment. That's usually what happens, and that's what they ask for. Are you going to be able to continue that, or are we going to have a problem?
I'm not aware of any current requests for advanced dish payments, but let me go back and check with the team and we'll circle back with you.
Well, what I'm saying is usually when they call you, that's what they're asking for in advance in the dish payment. Now, my understanding, there has been some question about advancing the dish payment from CMS. So are we going to have a problem, or are you going to be able to do it as we've done in the past?
So I don't misspeak, sir. Let me circle back with our finance team and we'll get back to you on that.
Commissioner, thank you so much. And members, thank you for your questions. Appreciate your presentation. Our next presentation will come from the Commissioner of the Department of Behavioral Health and Developmental Disabilities, Commissioner Judy Fitzgerald. Hey, Commissioner, thank you for being here with us today, and the floor is yours when ready.
No, thanks. I'm so sorry. Good morning. I'm sorry, Mr. Chairman, you ready? Excellent, great. Thank you. Well, good morning, Chairman Tillery, members of the General Assembly, and very pleased to have the opportunity this morning to bring to you the governor's budget for the Department of Behavioral Health and Developmental Disability. I am also pleased to give a shout out to Budget Workforce, yours, OPB's and mine, who've stuck it out through the weeks of coming to you to bring you a budget. And so I stand before you this morning, and right at the outset, I want to express my appreciation for the emphasis that this body has placed on mental health this year. You all have made it a priority to talk about improved access, decreased stigma, and raising awareness of mental health issues. Because what we know is that the isolation, uncertainty, grief, and loss during the pandemic has taken a marked toll and placed mental health at the forefront of all of our health concerns. So before I dive into the budget, I want to share some information with you this morning. I have 3 really powerful slides that actually have some unsettling numbers on them. But I think it's important to tell a story this morning. It's part of the story of your call for more attention to mental health. So with that, I begin. Next slide, first slide, please. Okay, got a slide full of numbers here, and I'm going to try and simplify them as best I can. These are national numbers that you're looking at here. On the right side of the slide, that first number that you see, 13%, 13% is the number of Americans who reported starting or increasing their substance use as a way of coping with COVID-19. Now, right below that, actually the number I think is really dramatic here. Excuse me, 1 in 4. That's 1 in 4 Americans who reported symptoms of anxiety and depression in 2020. That is up from 1 in 10 in 2019. That's a dramatic increase. And then, of course, you see that 25% figure of adults who reported unmet need for mental health treatment. Now to the left side of the slide. These are national numbers as they relate to kids. And these are painful, and many of you are already aware. That first number, 24% increase in mental health related visits to an emergency department for youth aged 5 to 11. 31% increase in mental health related emergency room visits for youth aged 12 to 17. Now, these numbers have been widely reported and have generated a great deal of concern, my concern and your concern, and it's important that we start there. Now, those are national numbers, but now I want to bring you to some startling Georgia numbers. Next slide, please. What you're looking at here are suicide death rates in Georgia. And what we're showing is a 10-year trend line. Now, listen, it's always difficult to talk about suicides, but it's important to stay grounded in the data when we talk about what are we going to do about this. But I do want to show you some interesting data here. Some of you have seen this before. You see 2 lines. The bottom line are overall suicide death rates in Georgia. And what you see there, this is covering 2011 through 2020. What you see from 2019 to 2020 is actually a reduction in overall suicides in the state. That top line you see, that blue line, that's actually an increase in rural suicides in Georgia, up 8.3% in our state. That meant 428 rural suicides in Georgia. And unfortunately, Preliminary data suggests that the 2021 figures are going to be worse. I want us to be grounded in these facts and to recognize the importance of the conversations we're having around mental health. You may be asking why, and there's lots more to be explored about why. What we know, isolation, stress, limited access, and the strain of the pandemic is having devastating consequences in our communities, our cities, and our families. Last slide. Okay, another painful slide with Georgia-based data. These are overdose deaths in Georgia. The time period here, if you can see it, January 2015 to January 2021. I want to draw your attention to that last uptick on the slide. What we've called out here is the period of April 2020 to April 2021, where we saw a 36% increase in overdose deaths in Georgia. That's 2,086 Georgians who died as a result of the disease of addiction. Now, I want to make a note about the role of fentanyl, which we know has added a lethal component to drug use. But that said, the key reminder here is our advocacy partners are always reminding you and us, the opposite of addiction is connection. And connections were what were difficult for people to find early in the pandemic. So there's a lot to absorb here, but this is what we're going to talk about. How do we foster connections and access? So all those painful numbers, the question now is, where is DBHDD and where are our state dollars in this? So let's go to the next slide, please. Okay, I've got a busy snapshot for you here. This is of DBHDD services for FY 2021. You've got a lot of numbers, but I want to show you how some of our investments are making a real life-saving difference for people in Georgia. Because despite those challenges we face, here's what I want you to know, and I'm going to call out just a few of these numbers here. That first one, 24%. Again, the impact of the pandemic, we had an increase of 24% in calls, texts, and chats to our Georgia Crisis and Access line. What you see in the next column, that top number, 20,395, when people call or reach out to GCAL, they try to diffuse the crisis or answer the question. In about 10% of those reach outs to GCAL, we need to send a mobile response. The person is in crisis and they need help now. So you can see in FY21, we actually had 20,395 dispatches of our mobile crisis. That was people met with professional help at that moment of crisis. In the third column, I also want to point to the top number, 32,700. If you can see it there, what that is a total number of admissions to short-term crisis and detoxification beds. Again, these are community services that we've built. And even despite the challenges, I do want you to know your dollars are hard at work in our service delivery system. A final note on this slide, because there's a lot of important takeaway numbers here. I do want to draw your attention right to the middle of the slide. That number, 15,607, that's Georgia students who received school-based mental health services through our APEX program. Many of you are aware because you've been supporters and you all have invested, as has Governor Kemp, in APEX, our school-based mental health. The idea of being meet kids where they are. And in the last 2 years, sometimes that's been meeting kids virtually. But I do want you to know 15,607 youth received services through that APEX program. We're in about 700 schools. Important to note that about 58% of those schools are rural schools. Another really important point, and I think a line of hope in these numbers, is that of those 15,607, for 1/3 of those students, it was their first time receiving mental health services. And that is what we're trying to do, reach folks at the earliest point that they recognize they need help. I believe all of these numbers are really what is focusing your call on a year of mental health. Again, I want to express our appreciation for the heightened awareness. And I really want to add that I hope it's not just a year of mental health, but where we are is stepping into an era of mental health in our state. And really, most of all, what this means is mental health is no longer an issue on the side. that Georgians and we all recognize that mental health is critical to overall well-being, and we make investments that reflect that. So let's talk about the budget. Next slide, please. Okay, here's another busy snapshot of Georgia's public safety net. That's who DBHDD is. That's who we are called in legislation to be. You've got a lot of information here. Many of you have seen this before. This reflects the vast service delivery system of our public safety net throughout the state. So I'm just going to hit on a few things and remind you, first and foremost, who we at the Department of Behavioral Health and Developmental Disabilities are called to serve is people with serious and persistent mental illness, substance use disorders, and intellectual and developmental disabilities. Our priority population are individuals who are uninsured and receiving Medicaid. So how do we do that? We do it through this network of community-based providers. And then the anchor of our safety net is our 5 state hospitals. And you see their locations there. Okay, let's talk a little bit more about funding. Next slide, please. Okay, this slide should be a familiar slide. I try and show this to you every year. And I think this slide is the best demonstration of Georgia's decade-long commitment to increasing community-based services. So there are 2 lines here. Even if you can't see the numbers, I think you see the trend. On that top line, the blue line, those are community-based services. Starting in 2010, where the state signed a settlement agreement with the Department of Justice to say we would decrease our reliance on hospitals and build up community services. Here's our clear evidence that we have set about doing that in really dramatic fashion, essentially doubling what's available in community-based services over that period of time. I'm really proud of what we built, and that's part of what's been responsive through these critical months. What you see along the bottom, the green line, is funding for our 5 state hospitals. And what you see there is consistent support over that decade. But I do want to turn your attention and talk a little bit about the impact of the pandemic particularly on our hospital and also our crisis systems. Next slide, please. Okay, so you saw that slide of increasing community-based services, terrific. What you see here, and this slide represents only DBHDD hospital staff, from the period of January 2020 up until January of this year, what you see is a dramatic loss of hospital personnel. And in fact, that net loss totals 1,096 individuals. This has presented extreme challenges for the safety net, but I want to call out 2 things because we've worked really hard to keep the safety net doors open throughout the pandemic. And there are 2 factors that have really enabled us to do this. First and foremost, has been a dedicated workforce. While you see many have left, more have stayed, and they've retained their commitments to the quality of care that we want to deliver across our hospital system. I really want to commend those who've stayed and retained their public service commitment. The second factor that has enabled us to keep the doors open, and this has been a vital lifeline, has been the support, Governor Kemp and his team making the decision to provide staff augmentation from Jackson Healthcare to our 5 state hospitals. That remains in place right now, and that is what enables us to continue to serve, keep safety net doors open, and allow our hospitals to continue to meet the call. Now, this is a workforce story. And I know you've heard this from every agency head and across every industry. I acknowledge that. But I want to make clear the extreme pressure that this workforce loss puts on our system and give you a reminder of what happens when individuals with disabilities, and very particularly individuals who are in psychiatric crisis in need of immediate care, what that impact is on our state. Next slide, please. Okay. What you're looking at here, again, in an effort to describe how the shortages impact our ability to serve, this is a slide that's simply from August of 2021 through December of 2021. And what you see is the continued impact of what we're calling here, because when we have reduced capacity, we call that we're taking beds offline. I want to just describe and make sure people understand what that means, because we're serving in healthcare facilities that are required to meet staffing ratios. If we do not have the staff, we have to reduce the number of beds that are available. That challenge continues right now. Right now, we are at the highest number of beds offline that we have been throughout the pandemic. And again, I know you're hearing this everywhere. The challenge is very real, but you've been hearing, and so I want to acknowledge, when people are in psychiatric crisis and they can't get to the place they need, they end up in the wrong place. Right? You may have heard that they're in hospital emergency departments. You've heard from law enforcement. You've heard from sheriffs. And I want to acknowledge the challenge that we're all facing. I also want to pause and I want to say thank you to our healthcare partners and our sheriffs in particular, who are facing the same workforce challenges. So they call with urgent needs. And really, in so many ways and so many times, we've been able to be creative and patient with one another and try and solve the problem at an individual level. We're grateful for those partnerships, but I think this slide makes clear the impact of those capacity demands. And one of the reasons why you all, and certainly Speaker Ralston, has talked about the intersect between law enforcement and mental health, because the needs are great and they continue. Next slide. Okay, so I've been talking thus far mostly about mental health and substance use. I have an important pivot here, thank you, to our service delivery system for people with intellectual and developmental disabilities. As many of you are aware, we serve about 13,000 individuals on now and comp waivers in community-based settings around the state. This is an important part of our budget and our responsibilities. How those individuals are served is through a network of providers. What those providers are reporting to us about their workforce challenges is present here in these numbers. Their challenges are every bit as real as we're facing in our hospital and community-based crisis settings. Now, there were workforce shortages prior to the pandemic, but what we know is it's beginning to reach a critical level that's impacting the ability for providers and families who are trying to navigate this, and many times on their own. They're calling out to you for help. Now, what I do want you to know is DBHDD was able, through some federal funds, to provide some temporary support, some flexibilities that allowed some service delivery that is normally not allowable. But what I think you're going to hear from providers is that it's all not happening fast enough. So we remain concerned about this area as well. So all of that is the context for which I bring to you the governor's budget for amended 22 and fiscal year 23. Thank you. I've got 3 slides to share with you about the DBHDD budget. Let's go ahead to the first one. Okay, first one is statewide changes. I'm not going to spend much time here. You've seen this same listing of changes for every agency. What I am going to talk about just for a moment is the importance of the $5,000 investment for state employees proposed in Governor Kemp's budget. All across our system, the increase in demand has been high pressure and has required our teams in every service setting to be relentless in their commitment. This $5,000 recognizes their value, their contribution as public servants, and really, I believe, is an incredible and important boost to the work and recognition of the work that they're doing. So I really want to acknowledge the importance of that. Only 2 other points I want to make on this initial slide. First, you'll see here, the only item we have in our amended budget is that $58 million investment, that first investment in the $5,000 for state employees. So that's our only amended item. The other comment I want to make while we're on this slide, because you're going to see we added a little something different to our slides this year. As I walk through on the next 2 slides, DBHDD's priorities, we tell you what each item is and what the budget allocation is. What we've also done is added a color-coded system. Here's what we want to do. Everywhere possible, show you and tell you how we think this budget investment helps solve a problem. Because I've talked to you today about the challenges we're facing. I do want you to feel like there's a connection to the investments we are making, and we're talking about making, and solving some of the challenges before us. Okay, you'll see that on the next slide. Okay, First slide on DBHDD priorities. And I'll talk about each one of these just so you're clear about what we hope the impact will be. First item, in the category of addictive disease, substance use, and adult mental health, we have a $7.8 million increase in 10% increase in core services. That means outpatient basic services all around the state that will enable, we estimate, about 10,000 Georgians, 10,000 more Georgians to access basic outpatient care. That's a significant investment in access. The next two items, and you can see that's coded purple to meet rising demand. The next two items are in the area of adult developmental disabilities. And this relates to investments in our now and comp waivers that enable people to live lives in the community. The first item, 1.9 million, is to annualize the budget for the 100 comp and now waivers that you allocated last year. So we'll annualize that. The third item there is 100 new now and comp waivers. So we'll begin the process of moving 100 more individuals off of the planning list and into community-based services. That's an important, again, interest in meeting the rising demand. Fourth item. This is in the category of adult forensic services. So just a reminder, forensic references individuals who have a mental illness and are involved with the criminal justice system. And what you see here, the program, the pilot program that's being proposed for 2.5 million is for a jail-based competency restoration pilot. So let me just explain for a moment what competency restoration means. When individuals with mental illness commit a crime and they come, as for example, if they come into our hospital, our goal is to provide treatment and also restore them to competency. That happens in our hospital. It also happens in community-based settings. What's being proposed here is something that's happening in a couple of other states where we're actually doing the competency restoration right in the jail. And there are some model programs, one in Colorado that we're looking at and hoping we can replicate here. How that impacts our capacity and allows us to bring more beds online. If we can do that in the jail, it reserves hospital beds so that, again, we can keep hospital beds open and moving. So this is a really important opportunity to do something innovative. Final item. Again, adult forensic services, 15 forensic peer mentors. So in case you're not familiar with that term, a peer is someone with lived experience. They're trained and certified then to work in settings all across our system. We've had peer mentors working with the Department of Correction and Department of Community Supervision. And I'm really proud to let you know that we've got terrific and consistent evidence that when forensic peer mentors are involved, there is a notable reduction in recidivism. The peer mentors are walking alongside that individual, helping to link to housing and other services, and really helping them to thrive in communities after they leave incarceration. So what the intention with the new forensic peer mentors is to go further into the prison system and to partner and to specifically identify individuals with mental illness who are returning to the community. Okay, last budget slide. Second grouping of DBHDD priorities. First item here, you see a 1.3 addition, once again, in an effort to meet rising demand, an enhancement of our Georgia Housing Voucher Program. Many of you are familiar. This has been part of our settlement agreement with the Department of Justice, and undergirding this is just the belief that housing is essential to recovery. So again, we're serving people with serious and persistent mental illness. Our GHV program is actually nationally recognized. And over the last 2 years, we've continued to take steps to digitize, streamline, and enhance the efficiency of these programs and add additional support so people not only access housing, but they remain in that housing as long as they need to move towards recovery and productivity. So that's an important budget enhancement. Item number 2 and number 3, I'll talk about those together. These are enhancements to our crisis system. So as you know, the need for additional crisis services is real. And the fastest and most expedient way for us to increase capacity in our crisis service delivery system is to add beds where we already have a facility. So that's what's being proposed here. In item number 2, the language we use here is to convert an existing crisis stabilization unit into a behavioral health crisis center. That's $3.7 million. Augusta is an area of tremendous need. What this enables, just to be clear, we're adding beds, but those additional beds in a BHCC allow for law enforcement drop-off. And that's been a significant driver and a significant area of interest. Also enables temporary observation beds for people who might not need more than a 24-hour stay. So we're doing that in Augusta. Then you also see an addition in Columbus, another high need area. We have a current behavioral health crisis center, and we're simply adding 13 more beds there in the amount of
Commissioner, I know there are a lot of changes in your budget. If you don't mind, I'm going to ask you if you don't mind to speed it up just a little bit because you have a substantial number of questions.
Looking forward to it. Okay, last 3 items here. The item number 4, Medicaid reimbursement. This emanates from a recommendation from the Behavioral Health Reform and Innovation Commission. The idea here is to allow providers to bill for more integration of primary care into behavioral health care, which we're finding is necessary for individuals with complex needs. I'll spend just a minute on assisted outpatient treatment, AOT. Because it's been an area of high interest from this body. Essentially, what AOT is a partnership between a behavioral health provider, the judiciary, probate courts usually, and law enforcement. We identify those individuals in local communities who are cycling in and out of care unsuccessfully. We provide additional support and monitoring. And when done properly, this is an evidence-based program. We have a single pilot underway. We look forward to expansion there. The final item on the budget, capital maintenance and repairs, $5 million. That's specifically across our 5 state hospitals where the environment of care is critical to the quality of services we deliver to patients. Just a reminder, our 5 state hospitals is actually 469 buildings across those 5 cities. So just want to acknowledge the importance of the environment of care and the impact that'll have. The support here is really critical. So with that, that's your whirlwind tour of the DBHDD budget.
Thank you so much, Commissioner. You got several questions. I think Commissioner Perkle is going to start. Our Chairman, Kirk Perkle, is going to start.
Thank you, Mr. Chair. It kind of hurt my heart when you talked about the 185 beds, critical care beds that are offline. We have capacity for physically, but that are not staffed. And we have, I think you mentioned, more beds offline right now than at any time during the pandemic. And we know that there is a need. We know that our law enforcement, our hospitals are bearing the brunt of having people in their custody that they have no place to send. One question, then one B. Is the additional money is going to help? I'm, as an economics guy, on the marginal it will, but will that provide sufficient help to help? We have these beds to get them online. And secondly, in part of the presentation, maybe it was a different program. We're adding additional beds in the critical care in 2 cities. Is that going to further compound the problem we're seeing now, or is that going to help eliminate some of the problems we're seeing now?
Okay, let me take the second one first. The hope is, again, where we already have a facility, they've already got a team working there. We know the demand is high, and we've got specific providers and facilities where they know the plan is to ramp up beds. We believe that is going to relieve part of the problem in those 2 areas. That's the hope there, and that's important. To your first question, right, this workforce challenge is real. Let me say a word about the $5,000 and what's critically important about one part of it. I see that first and foremost as an important nod to retention, because one of the things I want to do wherever possible, where we have skilled, trained, and dedicated workforce, I want them to feel valued and I want them to stay. That's really our best investment at the start. Now the question is, will that lift of those $5,000, will it bring other people in? We are more than willing to talk about what are all the creative ways that we can entice people into what I might add are really challenging jobs. But I think the opportunity is there. And I think Georgia is poised to take advantage of it.
Representative Lee Hawkins.
I appreciate all your hard work and everything you've been doing, and also work we look forward to in moving the ABLE account back to Georgia. Steve McCoy has been very appreciative of that and complimenting on you. But my question is this: looking at the budget, Georgia, we're increasing our investment in this area by 10%, and the federal funding stays flatlined. And in fact, it's very dismal compared to the other healthcare areas. Do you foresee any improvement in federal funding for the states?
I'm not sure exactly what you're looking at there. Let me just say a couple of words about how important some aspects of federal funding have been in the pandemic. The CARES and ARPA funds, and we had provided a presentation to a subgroup of you, happy to share more, have been put immediately to work. Specifically, I do want to call out children's mental health in particular, as well as addiction dollars. And we expect more out of the opioid settlement agreement. So we do have some areas where we are anticipating a pretty dramatic influx of federal funds to assist.
Yeah, I was referring to the 149 million that shows here on your table. I do know that CRF funding has been supplementing some of your areas, but it's still troubling to see that the federal funding is staying flat at 149 million every year, while Georgia's investment is 1,327,000,000. Thank you.
Thank you.
Thank you for all you're doing with mental health. My question is, I know we're under a consent order from the Department of Justice. Is there a plan to resolve that or a portion of that in the works?
Yeah, thanks for the question. Like you, there's nothing I'd like more than to move beyond federal intervention. So to be clear, the original agreement that was signed in 2010 put the state under a lot of obligations, both in mental health and people with intellectual and developmental disabilities. The state actually has exited from several obligations that are in the settlement agreement. Two major areas remain. What they are housing for people with serious and persistent mental illness and individuals who have intellectual and developmental disabilities who are medically and behaviorally complex and living in community settings, attending to their care. Those are the areas, major areas that are still under focus. I want to say out loud, we are making substantial progress in both of those areas, most especially in the area of housing. And I think we absolutely have turned a corner. And I will, unfortunately, at some point, I have to leave it to the lawyers to decide about whether that our progress counts as substantial progress to meet their demands. But I assure you, there's a lot of interest in moving forward. Our system change has been remarkable and noted. And if we can find a way to exit as a result of our evidence, I'm looking forward to doing that.
Senator Lucas. Jim.
Commissioner, I had an experience with a person that ended up and was diagnosed with a chemical imbalance. And they act normal, and then one day they just showed up. They were ready to fight all kinds of things. Now, what do we do with those folks? And you talk about community base. and then they can't make them take the medicine, so they act right. And the reason I asked that is we ended up in the same situation in Millersville with the mental institutions, and the government broke it up. We went to these community organizations, they were funded, and then they ended up with some of the same folks that they could not handle. So what happens then?
Yeah, thanks for your question. I think it's a fair question. So just to be clear, and I want to make one point in reference back to the budget, because the individual situation you described, because you specifically referenced people who had an imbalance and had difficulty with their illness and did not want to take medication. This is partly what that AOT, Assisted Outpatient Treatment Program, is really targeting: people at the highest level of need who are unsuccessful in their efforts at treatment. And what this enables, again, this is a partnership between law enforcement and the probate court and the behavioral health provider to in every way wrap around additional supports around people at the highest level of need and have additional monitoring for compliance with those elements of their treatment that they find it difficult to comply with. So I think there's some hope in some of the programs being put forward, but the emphasis, of course, throughout the country is on delivering community-based care and keeping those doors open in crisis and otherwise. And certainly that addition of core services, let me say a word about that. The hope there is, as soon as we see there's difficulty, we want to make it as easy as possible for someone to access help.
And the last word here, Chairman Knight.
Thank you, Chairman Perkle. And again, I want to echo what Chairman Perkle had talked about on the beds. Commissioner, thank you. I've had one of those constituent issues that I know you were very involved with. Your department came in, that involved law enforcement, police, hospital, ER visit, very sad situation. And you were able to get, help in the right place. And I think that is going back to, the facilities in bed. So I want to thank you for what you did and what your department's doing there, and support any effort that we can to make sure that these hospitals and these beds are not only fully utilized, but we need more of them. But in regards to a different matter, there are two things I want to talk about. One is the Apex program within the schools. One question is, are the parents also notified when there are issues with the students? Because this is a school situation and you've got a parental issue there. In other words, parents should be notified, when their child is in a mental situation, so that parents can also help. So I think it's important. But the other issue is in regards to some of these regional facilities that we contract out with the behavioral, where they come in. Obviously, my county has one in Griffin or Spalding County, but we're seeing an influx of folks coming in from surrounding counties where law enforcement folks are coming in, bringing these folks, dropping them off. They'll stay a day, two, and then they're back. And unfortunately, they're not getting either treated, don't want to get treated, but they're also congregating around these regional areas. So that's one issue that I think we need to address. And one of the other issues is in regards to addiction. Could you get us statistics on illegal drug, use as it relates to these statistics that you've shown us that involve mental health? Because there's not only we need to treat that, but we also need to prevent that. And we know that fentanyl and other drugs that are coming in illegally across the borders is a big deal. And it's not only costing us money, it's costing us lives. So there's multiple ways that we need to address this issue. Could you get us that data?
Absolutely. So I think I'm tracking all your questions here. First, yes, we certainly can provide any data we have, and we partner with public health on some of that data. And of course, want to acknowledge Attorney General Carr has led important efforts around the illegal drug part and been a great partner with us there. So yes, on data there. As to folks coming to I think you're referencing, I want to make sure, a crisis unit, right? So understand, this was true before the pandemic, but true now. where an individual is in crisis and they need to get to a crisis bed, we're trying to get them to the nearest place possible that we can. And as near to their home as we can is always the goal. But where there's a crisis, we want to meet them at that level of need as quickly as we can. That's what the hope is. The hope is also then to link them to community supports in their home community. And so that's what the goal is. That's what the discharge planning is to be about. But again, just the effort is to make those connections as we, as folks discharge from the units.
One follow-up piece of data, Chairman, if I will, and it'll be very quickly that you can add in. We're also anecdotally heard in hearings, a couple of hearings right before session. And we're also hearing anecdotally that a lot of these people that are coming in from other states. And that we're seeing a high number of folks who are coming to Georgia. And we're also anecdotally hearing that other states' reimbursement rates for mental health is lower than ours. And is there a correlation? What is behind a lot of people coming to Georgia with mental health issues instead of them, again, going back to their home place, their state of residency and seeking treatment there? Could you get that data or maybe and briefly speak to that?
What I can say briefly, I don't have the data before me. We did look at that where I had heard the same anecdotally a little bit more. There were some changes that were made. One of the biggest ones was the state of Alabama made a really big investment in their crisis services. And so whether or not in the end that meant a reduction in folks coming across, the challenge we face is when there's a person who is in active psychiatric crisis, making sure we're treating their need is of the utmost priority. We're often not in a situation where we can send them somewhere else if what their need is for urgent and immediate treatment. But we can take a look and happy to share some numbers around that. Last response on your APEX question. Let me say this about the APEX design of the program, because we're really intentional about it. How APEX works is it's a partnership between the school and a local behavioral health provider. And it gets at, I think, a little bit of your point. The school has to agree, and the behavioral health provider, the idea is that youth is not just an individual youth, maybe with a problem. They're seeking services. They certainly can do that in that school-based setting. But what we find often is really that there are family members in need of assistance as well. And so that's why we've connected to the community provider, as well as serving the individual, the youth who raises their hand and says that they need some help.
Thank you, Commissioner. That's all we have time for at this point. If there's some other questions from members I see on the board, if you'll take that offline, I would appreciate it. So next we have
thank you,
Commissioner Fitzgerald. Thank you for being here. Commissioner John King, our insurance commissioner. If you'll come on up, please.
Yeah.
Commissioner King, thank you for being here with us today.
Thank you so
We look
much.
forward to your presentation. Go ahead.
Mr. Chairman, Mr. Vice Chairman, thank you so much for allowing us to come and do this budget presentation and to give you the highlights of our approach to managing the budget that you have given us to operate our agency. First of all, I'd like to begin by announcing that I'm now the only official insurance commissioner on the payroll. So automatically, I've given you a savings to the state of Georgia. In all seriousness, we made some significant progress over the last few years, and we look forward to continuing to be good stewards of the tax
Commissioner,
dollars.
hold up just a second. If we have someone shut that door, that would be awesome. Thank you.
And I look forward to continuing to be good stewards of the tax dollars that you've entrusted us with. Our amended FY22 and FY23 budget requests include some significant changes from previous years. Most significantly, our budget now includes funding for both the new state reinsurance and Georgia Access programs as part of the Patients First Act passed by the legislature in 2019. On page 236 of your tracking sheet, you can see the adjustments reflecting the governor's proposed $5,000 pay increases for employees in our agency's 5 divisions: administration, enforcement, fire safety, special fraud, and insurance regulations. You will also see $8,049,000 for a completely new program. These are the initial funds for the implementation of the Patients First Act. $8 million will go to setting up the new Georgia Access website and all the program support, while the other $49,000 is the initial funds for the state's new reinsurance program. As Governor Kemp outlined in his State of the State last week, this reinsurance program has already reduced healthcare premiums by an average of 12% statewide, including up to 30% in some of our most rural counties. As you see in the FY23 request, our agency will begin fully manning this reinsurance program next year. And before I transition to the FY23 budget request, I want to highlight a few of our agency's accomplishments over the past few years. You have granted us a number of one-time budget requests during my time as commissioner, and we've been able to get some great work done with those dollars. In 2020, you provided us one-time funds of $125,000 to implement a surplus lines automation system, an online system that makes it easier for insurance to report policies to our office for tax collections. This online system replaces a former inefficient paper process that often resulted in mixed tax collections. We were able to implement the system in January of 2021, and after an adjustment period for the companies filing these policies, will be fully in effect in FY23. Our initial projected revenues were between $500,000 and $5 million, but I'm excited to announce today that FY22 collections are already over $13 million thanks to this new system. That's $13 million of new revenue directly to the state treasury from a $125,000 investment. We're also use new funds that you provided us to strengthen our agency's IT infrastructure and improve cybersecurity. We are the second largest revenue generating agency, bringing in over $1.3 billion annually. Yet when I took over, we were collecting these dollars either through paper checks or homegrown systems and a website built in the 2000s. With the funds you provided us, we've been able to upgrade these systems and move our agency in the 21st century. We recently launched our Georgia Insurance Management System, which let us move from processing paper checks to accepting online payments from everything from agents and agency license applications, staff adjusters, and name approvals. We've also implemented CitizenServe, a web-based cloud system that allows our safety fire division to electronically accept building plans, permits, and licenses. Effective July 1st of last year, CitizenServe also allows us to digitally track inspections from buildings, elevators, escalators, and boilers. This new system has already helped us to discover and address previously unknown holes in our inspection process to better serve the people of the state of Georgia. We also rolled out a new online system that helps us better collect and organize legal documents and more efficiently process open records requests from media and from citizens. This system also allows us to implement our new surprise billing authorities that we recently received as enacted by the state laws and by federal laws. Our safety fire side, we've moved to a new system for Georgia schools to report the required fire, tornado, and other safety drills to our office. This system is free to the schools. We're also responsible for providing fire safety training to all caregiver professionals in Georgia. Our new system is more user-friendly for caregivers and allows us to better track those certificates to ensure the training is up to date. On the operations side, our new SharePoint applications allow us to more efficiently track internal documents such as purchasing invoices and HR files. And finally, before moving to the FY23 budget request, I want to highlight two important divisions of our agency who are working directly for Georgia consumers every day: Consumer Services and Special Fraud. Thanks to the General Assembly, we've been able to add additional staff and resources to these two divisions. Our Consumer Services team works every day to answer insurance questions and helping us resolve disputes between insurers, agents, and policyholders. Thanks to their hard work, in 2021 alone, our agency recovered over $17.7 million from insurance companies back to the pockets of hardworking Georgia families. Our Special Fraud Division is made up of certified sworn law enforcement officers who investigate illegal insurance activities perpetrated by companies, agents, and individuals. In 2021, Special Fraud received a 156% increase in assigned cases and saw a 269% increase in arrests for charges ranging from insurance fraud to forgery, criminal damage to property, and exploitation of the elderly. Special Fraud recovered over $2.6 million for victims in 2021. I see my job as first being and foremost Georgia's consumer advocate, and your support has allowed us to better accomplish that goal. Moving to fiscal year 2023, on page 237 of your tracking sheet, shows the budget changes for our administration, enforcement, and fire safety divisions. For the administration and enforcement, the only changes reflect the governor's proposed $5,000 pay increase in retirement and earned leave changes. For the fire safety section, you can see nearly $1.2 million in increase for pay raises and retirement and earned leave changes. An additional $800,000 reflects a transfer for the insurance regulation program, and we will fund 10 new inspectors. 3 of them will be building inspectors, 1 fire investigator, 4 safety inspectors, 1 manufacturing housing inspector, and 1 hazardous material inspector. Moving on to page 238 of your tracker, you will see $277,000 in special fraud for pay raises and retirement and earned leave changes. We've also requesting $825,000 for 5 new positions and operations. This will complete our 2-year plan to fully staff the division. These positions include 1 compliance officer, 3 fraud investigators, and 1 financial forensic auditor. Funding for these positions will allow us to review all cases referred to our office and ensure each agent has a proper caseload. Fraud impacts everyone in Georgia, regardless of whether you're a direct victim or not, in the form of higher premiums between $400 and $700 per family every year. Special fraud funds are paid directly by the insurance industry and do not come from the state budget. The industry fully supports this funding, and in fact, they send us the majority of the tips that we investigate, and appreciate the work of our agency to tackle this fraud that impacts all Georgians. And further down page 238 of your tracking document, you will see our proposed changes in insurance regulation, beginning with $484,000 to pay raises and retirement and earned leave changes. And you'll also see $800,000 from transfer from the divisions, from this division to the safety fire division, as we discussed previously. We're offsetting this $800,000 by aligning other expenses. And additionally, at the bottom of page 238, you will see FY23 allotment for state reinsurance and Georgia Access programs as established by the Patients First Act of 2019. This amount is over $124 million for the state reinsurance program and will go to offset the high cost of medical claims on Georgia's individual market. Offsetting these high claims will in turn bring down healthcare premiums across Georgia. We're estimating the premium reductions of anywhere between 10 to 30%, depending on the region of the state. Our more rural areas where premiums are the highest will see the largest reductions. These funds include full-time position within our agency to oversee the reinsurance program. This position will be responsible for setting the reinsurance parameters, collecting and analyzing claims information, and managing the pass-through funding. The remaining $15.5 million will establish a new state-run Georgia Access website and program to replace the federal ACA exchange. These funds will stand up the new program and will cover enabling technology and staff. Under the Georgia Access, our office will be responsible for overseeing the individual market, certifying offered healthcare plans, and regulating how consumers shop for and enroll the health plans on this market. I thank you again for the opportunity to present our agency's priorities and how we worked and how we've been shown to be able to work on behalf of Georgia consumers. The support of this committee and the entire General Assembly is essential for us to be able to accomplish our mission, and we are grateful for this partnership. I will now open it up for any questions, Mr. Chairman, Vice Chairman, and I have here my financial officer, Chad Devello, to answer any of the technical questions, sir.
Thank you, Commissioner. Appreciate you, your presentation today. We do have a couple of questions. Representative Knight.
Thank you, Commissioner. And I'm glad to hear, again, you taking your role very seriously to protect Georgia citizens. It's so vitally important, especially the issues that are going on now. My question is, as you know, the General Assembly back from 17 through 19 passed a lot of legislation in regards to PBMs and specifically gave your office a lot more tools to help in the oversight of that, particular issue. Are you, from a point of view, needing, I don't see any reference to staff, but are you prepared, your office prepared to deal with these, these tools and use these tools in regards to the resources you need to go out and investigate these issues that we're protecting, patients and providers in regards to abuses that we're seeing within the PBM?
At this time, I think I have the sufficient resources to manage that program. We're looking at the complaint data, and we hear a lot of anecdotal concerns, but we're asking for the data from the companies, and they're providing us. So far, I don't see any. I think these companies are very clear on what the authorities that the legislature's given us. And so I feel that we have the sufficient resources to manage that program. Obviously, we'll have to revisit that on a yearly basis, depending on where the data takes us. But at this time, I think I have the sufficient resources to manage the program.
Senator Beach.
Thank you, Mr. Chairman. Commissioner, thank you for all you're doing, and thank you for bringing integrity back to the insurance department. My question is, and I know it's two private entities, Northside Hospital and Anthem, but there's a problem, and it got extended 30 days. And again, I know it's two private entities, but are you involved in any way to help resolve this issue? Because all of our state employees are on Anthem, and my constituents in Cherokee, it's one of my biggest employers, Northside Hospital. They're calling and wanting to plan elective surgeries, and they're being told they can't do it. So are you involved in that, or is there anything you can do to help resolve that problem?
We're working with both parties to get this resolved properly. I will tell you, Senator, I'm not happy because Georgia consumers at the end of the day are the ones being victimized in this, and they're being held hostage by two big players in this system. I've talked to both sides. I'm encouraging them to resolve, but clearly I know that my authorities are relatively limited, especially in contract negotiations. The legislature just has not given me the authorities, but I'm speaking very loudly to both of them, just as much as I know you are and other members of the legislature are not pleased, because I'm getting phone calls as well, even from my former employees with the Doraville Police Department who are caught up in the middle of this debacle. And so I'm not happy with either one of these parties at this point.
Chair Lady Oliver.
Thank you, Commissioner. I want to thank your staff, particularly Greg Conley, for meeting with the Behavioral Health Commission folks yesterday for a real drill down on the fast moving federal mandates on parity. As we move into this discussion of parity more extensively in the mental health bill that's coming, I believe you need at least one additional resource person in the Insurance Commission to help head up parity enforcement, which is a huge challenge. Would that be a fair statement?
Yes, ma'am. Of course, I'm not going to turn down any additional help. This is too important and I know I have a piece of this. This is a multi-agency approach. I know this is a priority not only to the governor, but to the speaker as well, as I know it is. And as a former chief of police, I know who ends up dealing with folks in crisis. It ends up being a law, and they're ill-equipped to deal with this. So obviously, any help, we're studying right now what's coming out of the federal pipeline, but we're also looking at what's going to result out of the legislative action that you all are contemplating at this point. But I could obviously use the help, and we need to generate that data.
The federal mandate to me is clear, and the Georgia enhancement of that is coming, I hope, pretty quickly. So we'll be working together. Thank you very much.
Thank you, ma'am.
Representative Donahue.
Commissioner, I want to thank you. Senator Beach hit my main question. Every day it seems that people are reaching out with the negotiation of Northside and Anthem. Actually, this affects me. I was looking at knee replacement and now can't do that. But I want to reach out really to let you know, thank you for the transparency. Anytime we reach out, you're there. That means a lot. I have constituents I spend quite a few hours every week dealing with problems, and you're always an open door policy. And people need to know that because it's not always been that easy. And that's something that is noted, and I do thank you for it.
Well, thank you for the opportunity. I take this mission, it's very important. And ultimately, I serve Georgians, and regardless of what their background, and we take a lot of pride. We are a service agency, and we look forward to continuing to serve. Thank you.
Commissioner, I have an additional question. Recently, this legislature has taken up PBM legislation. Did we task your department with follow through and enforcement of that legislation? And if so, is there any other additional resources you need there?
So far right now, Mr. Chairman, I think we have the resources necessary right now. We're in discussion with all the PBMs about, gathering the data. We're monitoring very closely the complaints coming in. And so we're figuring out, the federal government has also added some authorities for us, for our agency. We are going to be the primary, precursors of the authorities to be able to also enforce some of the federal mandates there. And so I think at this point, it doesn't mean that I'm not going to come to you next year for asking for additional resources. But at this point, I think we have the sufficient resources.
Thank you for your answer on that one. You've extinguished all the questions. We would be remiss, and I want to give this body an opportunity to thank you for the other hats you wear and your service to our country. And we are indebted to you for that as well. Thank you for being here and what you do when you're not in your role as insurance commissioner as well.
Well, thank you so much. I appreciate it.
Thank you again. We have reached the time you've all been waiting for, the last presenter. Our next presenter will be the Governor's Office of Planning and Budget Director, Director Kelly Farr. Director Farr, welcome to the podium, and the floor is yours.
Thank you, Mr. Chairman. All right, good morning. Chairman Tillery, Chairman Perkle, Chairman Burke, and members of the committee. I want to thank you for the opportunity to appear before you today. I want to begin this morning by offering my prayers and condolences to Chairman England, his wife, and their family. While serving as OPB director, we have seen some dramatic year-over-year shifts in the budget. I can recall April, May of 2020, the meetings with Treasurer McCoy, his team, Dr. Dorfman, and others reviewing the dire cash flow projections with red everywhere. As we have those same meetings today, they are considerably more positive and include a lot of green. None of that would have been possible without the strong conservative leadership of this body and the governor. As the governor mentioned in his comments earlier this week, he is more optimistic than ever about the strength of the state's economy. And as a result, his budget makes historic investments in our education systems to ensure that we are fully meeting our obligations as a state to our teachers and students, while also making some additional tremendous one-time investments across a number of budgetary areas. The strength of our position today would not be possible without the partnership the governor and OPB has had with each of your committees. And I specifically want to thank Chairman England, Chairman Tillery, Director Wigton, Director Debussy, and the staff at the House and Senate budget offices. You all have helped us in the state navigate those difficult financial decisions we've had to make over the last 2 years, and we are grateful and better off for your help. I know how precious your time is and the number of commitments you all have, but you've all been willing to carve out time to offer your support and thoughts. I am personally thankful for all the advice and leadership that you all have provided to me. There are a number of items in the governor's budget proposal that are a result of this collaboration and these discussions. Addressing maternal mortality by lengthening postpartum Medicaid coverage for new mothers from 6 months to a year. Removing attestation requirements for Medicaid physicians to level the playing field on reimbursement rates for providers. Establishing a high-demand career initiative program to expand apprenticeship opportunities for use. Increasing the percentage of tuition covered by HOPE to help our students access affordable higher education opportunities. Implementing the findings of the Behavioral Health Reform and Innovation Commission to establish 3 additional assisted outpatient treatment programs and increase the number of forensic peer mentors to help offenders successfully transition upon reentry. Increasing staffing and equipment for both our crime labs and medical examiners to address forensic backlogs, and dedicating over $200 million in fees to newly established trust funds to ensure they are used as intended. And this is just to illustrate a few of the initiatives that are in the budget. I truly appreciate the feedback and insight that I've gotten from each of you over the past summer and fall ahead of the governor introducing his budget. And I hope that we will continue this close working relationship between all of our teams going forward. You've heard this week from many of our large state agency heads on a number of initiatives included in this budget. However, I want to take a minute to highlight a few items I think really showcase the good government and continued conservative fiscal management of the state. Within the Department of Administrative Services in the amended budget, you'll see $150 million to negotiate settlements on outstanding workers' compensation claims, some of which have been pending since the 80s. These funds will hopefully clear up a large backlog to ensure we're meeting our obligations to those employees who have served our state. This is one of the first issues I spoke with Chairman Hill about when I became OPB director. With the continued championing of this issue by a lot of you, I'm glad to see this make it into the governor's budget proposal. We are also investing $118 million in the employees' retirement system to provide a COLA to retired state employees, increase the employer match for our GSUPS employees from 3% up to a maximum of 9%, provide a pool to fund forfeited leave for retiring state employees. That last item is extraordinarily helpful, in particular in many of our smaller state agencies who have in prior years had to come to the General Assembly to ask for additional appropriations to cover the retirement costs of a longtime employee. Agencies often have to hold funds aside in their budget they would be spending on other operational needs or filling that job more quickly to cover any of these potentially unexpected large payouts. These changes will greatly increase the fiscal planning for our agencies while also helping them recruit and retain employees with enhanced GSEPs match. There's also $51 million in the Empowerment Fund the General Assembly established at GTA that will enable the state to implement a next generation enterprise accounting system to replace TeamWorks. Our current system is nearly 20 years old. A newer, more modern system will be more user-friendly, better able to automate critical financial processes to reduce manpower, provide enterprise data on a financial position of our state agencies, and also be more responsive. And that's one of the things I've learned a lot in the last few years is that we need to try to figure out a way to establish our technology so it can evolve as quick as things are changing now, because it's literally changing month to month, year to year. We're putting $31 million into the amended budget to replace aging fleet and equipment at state agencies where we would otherwise be spending more to repair and maintain these items than they are now worth. And we're putting more than $167 million into agency budgets in FY23 to fund ongoing facility maintenance and rehabilitation needs and agency operational budgets, rather than annually using our capital outlay package and paying interest to meet those ongoing needs. Our conservative fiscal stewardship translates into additional savings to our taxpayers. Thanks to our AAA bond rating, we continue to realize historically low rates on the state's bond sales. You'll see $120 million in debt service savings in the amended budget as a result of those low rates. Now, with regards to OPB's specific budget, the changes to our budget are the statewide recommendations that you've seen in most state agencies, such as the pay adjustment for state employees, to fully fund the ADEC for our ERS and TRS eligible employees, fund a COLA for the retirees, increase the employer match for the 401k, fund the employer share of forfeited leave for retirees, allow eligible employees to withdraw up to 40 hours of earned annual leave. And the last is the DOS agency premiums and teamwork billings. This time, I'd be happy to answer any of your questions.
Thank you, Director. I want to start off first with just a few comments. Some of the things you highlighted, the extinguishment of liabilities in this budget, whether those be property liabilities or workers' comp liabilities, or even retirement, that time after time this body is asked to address because someone's built up years of retirement and their retirement alone is, 25% or 20% of the entire agency budget. You probably won't hear very many people in the hallways or on the writing newspaper articles letter commend you on that. But I want to tell you, as someone who has to study this budget year round, thank you for working. I think Georgians in the future will be thankful for the investments that you've made here. And I want to highlight those and tell you thank you for that personally. You do have a couple of questions, Senator Beach.
Yes, thank you, Mr. Chairman. Director, thank you for all you've done on the budget. Great job. Thank you for your presentation. My question to you is, I know there's an opportunity, we may have some federal money coming down for infrastructure, somewhere in the $600 million range, and we're going to have a 20% match. What I don't want to do is take money from existing projects that are already in the program. Do we have a game plan for that if that money does become available? I don't want to take House Bill 170 money that's already ready to be implemented just to meet that match, but I don't want to not take the 600 million.
I think that's a question best for DOT, but I would say that DOT, through all the different funding mechanisms it has available for it, whether it is money that they have at the Treasury or money they have for motor fuel or HB 170 or rideshare fees or whatever, I would feel confident that they have the flexibility to manage whatever additional match may be necessary. In addition, these additional 600 million is also spread over a number of years, right? It's not just this first year. Yes, sir.
Thought we had another question, but it went off. Senator Lucas, was that? Senator C was ready to cut you off, though. I tell you, you got to watch your colleague over here.
Director, I want to ask you a question. There's talk of exempting veterans retirement in Georgia. You have any idea what kind of money we are talking about?
There was a fiscal note done on it. Maybe off the top of my head, I remember around 70 million.
Okay, I just wanted to figure out. I mean, when you take money out the general treasury, you got to find a way to put some back in.
Are there any questions online, Chairman Perkle? No, sir. Director Farr, there are no more questions in the room. Thank you so much again for your presentation. Appreciate you being here today.
No, thank y'all. And I sincerely appreciate y'all's partnership. I mean, a lot of the ideas that you find in this budget proposal came from a lot of conversations with y'all. So,
I'm glad you said that. I also want to thank the governor and thank you that I have heard that same comment from many of the members that they feel that they saw reflections in this budget of things they had brought up in years before. And the comment that I heard, the word I heard most was possibly listening. And I want to give your department credit for that as well.
Thank you.
Members, thank you again, Director.
Thank y'all.
Members, we have reached the end of presentations from department heads. I want to tell you all, thank you so much for sticking with us over the past 3 days. I know your role is vitally important to the citizens of our state as we work through this budget process. And as you now move into your subcommittees, for those who are listening who may not be as familiar with the budget process, the budget work does not stop here. It actually begins. And the members who you've heard ask questions, among others, will now roll into subcommittee roles on the House and the Senate, and will ask these same questions and more in much greater detail as they can break down the various elements of the budget as we work for you, the citizens, the 11 million citizens of the state of Georgia. And thank you for allowing us to do this on your behalf. There is a meeting after this meeting. As you know, we will break for lunch, but as required by federal law, the federal block grant hearing will begin again at 1 o'clock as advertised in the statewide newspaper. And at that point in time, I believe Chair Lady Dempsey and Chairman Watson will be presiding. We thank you for the time they're going to put in then. And you are all welcome to join back at that point in time as well. Commissioner Perkle or Chairman Perkle.
Commissioner, I don't know where that puts me, but today's presentations, last housekeeping announcement. Today's presentations, the video presentations for the entire week are archived on the House website. So those that you missed, those that you'd like to go back, they will be archived. They will be available. There were some very good presentations. And as the chair mentioned, House subcommittees will be reviewing the fiscal year 22 amended on the schedule beginning next week. So watch your calendars. We've got a lot of work to do. You're so very diligent. Thank you for your diligent questions and staying awake and for what you do for this great state. Chairman?
That is all. We stand adjourned.